seat on the front before we begin. The ones on the back, yang di belakang boleh minta tolong untuk mengisi kursi yang di depan ya. Terutama yang bagian sini sih, karena aku lihat masih kosong-kosong. Boleh minta tolong ya. Oh ya, mungkin untuk yang baru hadir, dipersilahkan untuk duduk di kursi bagian depan ya. Oke. Before we begin, let me test the waves, let's say in Indonesia. Good morning, everyone. Morning. When I say good morning, you say morning, okay? Got it? Okay. Good morning, everyone. Okay. Oh, I hope everyone is having a good morning. Even if you are having a bad morning, hopefully it gets better. Good morning and warm greetings to everyone. Honorable Associate Dean of Erlangga University's Medical Faculty, Head of Indonesian Association of Midwifery Education, AIPKIN, Honorable Clinical Instructors from Hospital, Puskesmas, or Public Health Center, and TPMB, Midwifery Private Practice in Surabaya, distinguished speakers from Western Sydney University and Erlangga University, and all respected participants who have joined us from various places, whether you are joining in this hall or from the Zoom meeting. First of all, let us express our gratitude to Almighty God for His blessings and grace, so that we are able to gather today in good health to participate in this midwifery webinar. Allow me to introduce myself as the Master of Ceremony who will guide you throughout today's event. Hello, everyone. My name is Farah, and I am a student of Erlangga University's undergraduate midwifery study program. It is truly an honor for me to accompany you in this meaningful and insightful session. The theme of our webinar today is Recent Best Evidence to Provide Compassionate Care, which is expected to broaden our knowledge, enhance our understanding, and strengthen our competencies in the ever-evolving field of healthcare. Before we proceed, allow me to present the list of agenda for today's event. We start with opening, then together we will sing the national anthem of Indonesia, Indonesia Raya, followed with Hymne Erlangga. Continued with remarks from the Associate Dean of Erlangga University's Faculty of Medicine that will be represented by Erlangga University's Midwifery Study Program, and then remarks from Head of Indonesian Association of Midwifery Education, AIPKIN, and then presentation by the speakers, followed by question and answer or Q&A session, and finally, closing session and documentation. All right, moving on to the next agenda. We will now sing the national anthem of Indonesia, followed by Hymne Erlangga. Please, everyone, stand up formally and let's sing along. For Himna Erlangga, please make a fist with your right hand, like this, and put your hand on your left side of chest, and let's sing along. Thank you, everyone. You may all be seated. Ladies and gentlemen, we will now proceed to the next agenda, which is the remarks from the Associate Dean of Erlangga University's Faculty of Medicine that will be represented by Erlangga University's Midwifery Study Program. To the Honorable Representation of Erlangga University's Midwifery Study Program, Ms. Dwi Zeti Budiono, Bachelor of Midwifery, Midwife, Magister of Science, we respectfully invite you to deliver your remarks. The floor is yours. Yes.
Okay, thank you. Good morning. Assalamualaikum warahmatullahi wabarakatuh. Thank you for being here today, both in the room and joining us online as well. Yeah, it is very great to see such a big interest on our webinar, and I forgot the title, Recent Best Evidence to Provide Compassionate Care. And on behalf of the Midwifery Study Program, Faculty of Medicine, Universitas Erlangga, I would like to warmly welcome all of you, especially our distinguished guest, Mrs. Jumiarni Ilyas, the chair of IPKIN, or Associations of Indonesian Midwifery Educations. And thank you for your presence and continued support in strengthening midwifery educations in Indonesia. And also our wonderful speakers Dr. Hazel Keedle, Professor Hannah Dahlen, and Dr. Wahyul Anis. We're lucky to have you all here. And also we have students from Western Sydney University.
Hi.
And from University Brunei Darussalam. And some also joining online from the students from Timor-Leste. And also our lovely preceptors here, who both joining online as well. And some also, thank you for coming, Ibu. I think what makes not evidence-based, but also should be compassionate, respectful, and really women-centered care. So I hope this time we have space to learn, also reflect, and have a good discussions, because the least we can do for this activity will bring more beneficial for us all. I think that's it. Thank you again for being here today. I hope this will be very meaningful sessions for you all. Assalamualaikum warahmatullahi wabarakatuh.
Thank you very much to the representation of Erlangga University's Midwifery Study Program, Ms. Diza, for the inspiring and insightful remarks that have motivated us all. Moving on, we welcome Head of Indonesian Association of Midwifery Education, IPKIN, Dr. Randa Jumiarni Ilyas, Magister of Health. We invite you sincerely to deliver your remarks. You may join us on the stage. Monggo, Ibu. Iya.
Assalamualaikum warahmatullahi wabarakatuh. Yang kami hormati Profesor Hannah dan kemudian Associate Profesor Hegel, kemudian Ibu Dr. Yulianis, dan seluruh pimpinan Fakultas Kedokteran, khususnya program studi kebidanan. Kemudian ada di sini 9 orang mahasiswa dari Brunei, ada sini. Kemudian dari Timor Leste, ya di sini tentu saja 13 mahasiswa dari Sydney University. Kami dan juga preseptor, seluruh dosen dan mahasiswa UNER yang mengikuti internasional webinar pagi ini. Webinar ini dengan mengangkat tema yang cukup menarik dan cukup hangat dibicarakan saat ini di Indonesia, karena ini adalah topik-topik yang berkaitan dengan suatu pengembangan dari model praktek kebidanan yang tentu saja pengembangan ini berdasarkan riset. Nah, hasil-hasil riset yang nanti akan dibahas pada tema hari ini, pada hari ini adalah suatu tantangan dan dorongan bagi kita semua untuk mengembangkannya, mencari yang cocok untuk kita seperti apa. Di Indonesia memang saat ini pelayanan kebidanan ini memang merupakan suatu kebutuhan yang besar dan mendesak untuk kita semua. Para akademisi tentunya punya kewajiban untuk mengembangkan riset-riset yang berkaitan dan pengembangan profesi dan pendidikan kebidanan di Indonesia. Kita sekarang punya pendidikan cukup banyak, profesi lebih kurang, pendidikan profesi lebih kurang 200, pendidikan diploma 3 masih punya sekitar 350, kemudian pendidikan magister kita punya 12, dan mudah-mudahan tahun ini ada satu S3 kebidanan yang akan segera dibuka. Ini semuanya adalah upaya-upaya kita untuk mendukung pengembangan pelayanan kebidanan melalui penyediaan SDM bidan yang berkualitas. Tentu saja bagi kita yang belum berkesempatan mengikuti perkembangan peningkatan pendidikan, ini peluang-peluangnya cukup banyak. Jadi kita bertanggung jawab terhadap pelayanan perempuan dan keluarga di Indonesia, khususnya ibu dan anak, yang merupakan sasaran pelayanan kebidanan. Tidak sedikit kita temukan masalah-masalah saat ini yang berkaitan dengan kebidanan, pelayanan, baik itu di rumah sakit, puskesmas, maupun di TPMB. Masalah-masalah yang dihadapi oleh teman-teman di TPMB cukup besar. Ini kalau kita bisa mengembangkan model seperti ini, mungkin merupakan suatu advokasi pada pemerintah untuk memperbaiki regulasi-regulasi yang mengekang para bidan untuk mengembangkan model prakteknya yang otonom di bidangnya. Jadi kami dari pendidikan selalu berusaha bersama teman-teman dari prodi-prodi untuk mencoba mencari model-model yang pas dengan filosofi profesi bidan, sehingga nanti ini merupakan advokasi ke pemerintah. Saat ini tidak sedikit upaya-upaya yang dilakukan melalui berbagai komunitas bidan, apakah itu organisasi profesi IBI, asosiasi pendidikan, maupun juga sekarang ada kolegium. Nah, dengan harapan ketiga unsur kebidanan komunitas bidan ini mestinya bersatu untuk mencari solusi bersama. Kami juga saat ini sedang mencoba merintis, mencoba mencari suatu bentuk pengembangan profesi bidan ini melalui penyusunan penyusunan suatu program yang bisa menampung ke seluruh pengembangan, apakah itu pendidikan ataupun pelayanan dan riset. Kami berharap ini merupakan suatu bentuk yang nantinya bisa merupakan dasar dalam pengembangan pendidikan dan pengembangan pelayanan di Indonesia. Dengan harapan masyarakat Indonesia, khususnya kaum ibu dan keluarga akan menjadi keluarga yang tidak hanya sakinah mawaddah, tetapi juga keluarga yang berkualitas sesuai dengan harapan-harapan profesi bidan, yaitu adanya perempuan-perempuan kuat yang mempunyai kemampuan untuk menyampaikan suara-suaranya untuk mencapai cita-cita para perempuan sehat dan kuat untuk membangun keluarga yang sehat dan kuat, sehingga nanti bangsa kita akan menjadi sehat dan kuat. Saya kira itulah cita-cita kami dari pendidikan, dan asosiasi pendidikan kebidanan ini berfungsi untuk mendorong para pendidik, apakah itu preseptor, apakah itu dosen atau penyelenggara pendidikan, untuk berkomitmen bersama-sama kita mengembangkan profesi ini. Tanpa kita bersatu, kita akan lemah, tapi kalau kita bersama, kita pasti kuat. Terima kasih. Selamat pagi, terima kasih atas perhatiannya. Mudah-mudahan pesan-pesan ini juga sampai nanti pada yang lain yang mungkin tidak hadir langsung di sini. Selamat siang.
Thank you. To the head of Indonesian Association of Midwifery Education, IPKIN, first of all, I would like to translate a bit for our international viewers. Miss Jumiarni Ilyas told us that she welcomed us all from wherever we are, from Zoom meeting or from this hall, especially to our guests from Western Sydney University, University of Brunei Darussalam, and also from the University from Timor-Leste. And also, Dr. Randa Jumiarni Ilyas explained that the midwifery the midwifery profession is based on evidence, and also we need to evolve our knowledge because every single knowledge about midwife and healthcare always evolves as time passes, and we also need to uh, and we also need to oh we need to keep up with the needs our of our people, especially in Indonesia. And also, IPKIN, the Association of Midwifery Education of Indonesia, also told us that we need to advocate to the government about the midwifery profession so we can evolve our care, especially because it keeps on evolving. And also, they are also trying to open a doctoral program, study program in Indonesia, especially because we don't have that right now. And also, IPKIN have told us that they hope for a harmonic for a family that will live in harmony, and also healthy children that will and for healthy children, healthy and strong children that will lead our nation. And also they encourage us as teachers to commit to the midwife program and stick together, because if we stick, we are strong, but if we separate, we will be weak. Okay. Moving on, we will enter the main session for today, which is the discussion about recent best evidence to provide compassionate care. For this next session, it will be led by our moderator. To the moderator, you may begin. Everyone give a round of applause.
Thank you so much, Farah. Ladies and gentlemen, good morning. First of all, allow me to extend my sincere appreciation to our Master of Ceremony for setting such a warm and welcoming tone to begin today's session. I will now take over as your moderator for the rest of this webinar. Distinguished speakers, respected guests, and all participants joining us both on-site and online over there from the Zoom as well as the YouTube Live. Thank you for being here. It is a pleasure to see such an engaged and enthusiastic audience gathered for a topic that truly matters. My name is Emma, and I'll be guiding all of you through the session today. I must say, it is quite refreshing to see such bright energy in the room, and equally encouraging to know that many more of you are tuning in virtually over there. Yes, it tells us one thing very clearly: the interest in improving compassionate care through evidence-based practice is not only present, but growing. Before we begin, just a quick note to ensure everything runs smoothly. For those joining us on site, should you experience any technical or logistical issue, audio like visibility or seating, please don't hesitate to reach out to the committee nearby. And for our online participants, if there are any interruptions such as unstable connections or audio difficulties, we recommend rejoining the session or checking your device settings. Our team is also on standby to assist you through the platform. Now, just to get the flow of today's session, after each set of 3 speakers, we will open the floor for a Q&A discussion directly. So if there is something that sparks your curiosity or challenges your perspective, we warmly encourage you to raise your questions when the time comes. Now, ladies and gentlemen, today's webinar centers around a highly relevant and impactful theme: recent best evidence to provide compassionate care. Throughout today's session, we will explore how recent evidence shapes care across 3 critical stages: antenatal, intranatal, and postnatal. We certainly hope that by the end of this webinar, all of us will walk away not just with new knowledge, but with a renewed perspective on how we approach care in our respective roles. So without further ado, let's get started. As we move into our first session, may I kindly invite all of you to direct your attention to the screen where the CV of our first speaker will be displayed. I always find this moment quite important because it emphasizes that the next 40 minutes are not just another session, but an opportunity to learn from someone whose work and expertise have truly made an impact in the field. So yes, this one you want to stay fully present for. Now, ladies and gentlemen, our first speaker is someone whose contributions speak for themselves. She is a respected academic and practitioner, widely recognized for her dedication to advancing maternal healthcare through research and evidence-based practice. Allow me to introduce Dr. Hazel Keedle from Western Sydney University. So, Dr. Hazel Keedle is a senior lecturer of midwifery at the School of Nursing and Midwifery, Western Sydney University. Hazel has more than 2 decades of experience as a clinician in nursing and midwifery, educator, and researcher. Hazel's research interests are vaginal birth after cesarean, birth trauma, and maternity experiences explored primarily using feminist mixed methodologies. Dr. Keedle has received notable recognition, including the SEM and SW Pat Purdue Research Scholarship awarded in July 2019, and she completed her doctorate in philosophy in 2021. She has also been an active member of the Australian College of Midwives from 2009 to 2020. Dr. Keedle focuses on several important areas, including birth trauma, midwifery practices, as well as pregnancy, childbirth, and the postnatal period. One of her key areas of expertise is vaginal birth after cesarean, or VBAC, which is a highly relevant and evolving topic in maternal health care. Dr. Keedle's work is recognized nationally and internationally, with many invited conference and seminar presentations, including academic publication and a book for women based on her PhD findings, Birth After Cesarean, Your Journey to a Better Birth. She is the lead researcher on the largest maternity experiences survey, the Birth Experience Study. Like everyone, what an impressive and inspiring journey. It is always remarkable to see such a strong commitment, not only to academic excellence, but also to meaningful real-world impact, particularly in a field as vital as maternal care. So, ladies and gentlemen, next, please. Ladies and gentlemen, this session, Dr. Hazel Keedle will be sharing her insights on the topic, recent best evidence in antenatal care. This is a crucial area that shapes the very beginning of the maternal journey. We are truly fortunate to be learning from someone with such depth of expertise. At this time, I would like to invite all of you to give a warm round of applause as we welcome Dr. Hazel Keedle to the stage. Ladies and gentlemen, please give a round of applause for Dr. Hazel Keedle. Doctor, please step up to stage and go right ahead for the presentation.
Oh, is this on now? Yeah, excellent. Okay, well, thank you for having me here today. We've had such a wonderful time here. I can't believe we only have a few days left. And it's a great honor to speak to you all here in the room and online. Hari ini saya akan berbicara tentang kekuatan kebidanan. So today I'm going to speak on the power of midwifery. Is this my slide thing? Oh, yeah. I'm going to focus on the results that we've had from the birth experience study, and in 3 particular areas. But let's just remind ourselves from last week what the birth experience study in Australia was. We had, this was live in 2021. We had over 8,804 women complete our survey from across Australia. And we had a lot of open text questions as well, on over 54,000 responses, written responses from women. But today we're going to focus on 3 main papers. And we have grown. We started off in Sydney with Hannah and myself, and then we grew. We were so We really believed in the power of our survey to highlight women's experiences. So we reached out across the globe, and we have been working with research partners across Europe and across Central and North and Southern Asia as well, which I'm particularly proud of working with Universitas Erlangga. So we have published 9 papers so far, 8 from Australia and 1 from the Netherlands. And the ones we're going to look at are, not sure if my little pointer works. Nope, back one. Okay, so we're going to look at the middle one. We're going to talk about the one on the end that says debriefing. And there's one more we were going to look at. The What Women Want paper. So they're the 3 that we're going to look at today. Next slide, please. All right. So there's 3 main things I want to look at. One, we've got the structure of the models of care, like and how important that is, and what women actually say about their models of care. It's one thing for us to design and have models of care that suit midwives, but what is it that women actually say about those models of care? The next then is, what do they want about their entire healthcare? What do women say about the type of birth they want, about where they want to birth, and who they want to birth with? And then finally, how do women want to be treated after they've had that baby? Whether or not they had a positive or a negative experience, how do midwives then help women process their birth experience? So they're the 3 things we're going to look at. Now, just a quick education for you about our models of care in Australia. This is a little bit out of date, but the website wouldn't work for me last night to get an updated image. But basically, we have lots of different maternity care models in Australia, and there are quite a lot of differences to what you have here in Indonesia. We do have private midwives. They tend to attend women's homes and home births, where they don't have their own clinics like your TPMB. But we don't have the puskesmas, so we don't have that primary healthcare setting as much. It's kind of either a private midwife in their own home or the hospital. But within the hospital, there can be lots of different models of care that they can access. So you can see the most common, this is Australia data from 2021, but the proportion that's the highest model of care is seeing a different midwife or doctor at every appointment, whoever's on shift for labour and birth, and whoever's around on the postnatal ward. That's the standard care. We tend to use the English word fragmented because it's in lots of different pieces. Then we have GPs. So you have GPs, so they might see their doctor in the community, then they might see, then they'll come into the hospital. We do have midwifery continuity of care models, like some of your students are now doing in the continuity of care. But this is when they see the same midwife or a small team of midwives during pregnancy and labour and birth. The midwife is on call for the woman's labour and birth, and then sees them afterwards as well. And we sometimes call that midwifery group practice in the hospital. And then there's a whole lots of other things. We also have private doctors, and, lots of different things that we can see in there. But you can see that the majority are going through standard care. But our midwifery group practice is growing slowly. So in our survey, with all of our many questions, 130 questions, we asked women if they had any other comments about their healthcare provider. We didn't say good or bad. We just said, do you have any other comments? And we then worked with a researcher from America that came to stay with us on a Fulbright scholarship. And we had her analyze all of those comments. And we separated it by model of care. So we looked at all the comments in the standard fragmented model. We looked at it with the midwives, with the doctors, and so on. In the standard fragmented model, there was also a high risk model. So if the woman had a high risk factor, where she would maybe be seen by only doctors, but also fragmented, different ones each time. Then with those comments, I hope I haven't lost you yet, we've got those comments, we separated them out into the different buckets of models. We then realized that there was some more positive comments and some more negative comments. So we went into that level to actually count how many were positive and how many were negative for each model of care, and then compared them. So what you can see on this slide is that in both the high risk fragmented care and the standard fragmented care, there are 86 and 88% of negative comments. Imagine that. We've got a model of care that most women in Australia experience, yet there was 86% of negative comments. There was some of the themes that came out of that was just having to constantly repeat your story. Every time you go and see a new midwife or a new doctor, you have to tell your story over and over and over again. Trying to navigate conflicting medical advice, especially in the high-risk group. Women felt that 1 week they'd be told to do this, this, and this, and then in another appointment, they'll be told to do this, this, and this. And there wasn't consistent information. And that's confusing when a woman is pregnant and trying to do the right thing by her pregnancy. And then just feeling like you are part of a system, like a piece of a bigger machine, and not feeling like a human. Now, if you remember from the webinar last week when I talked about obstetric violence, feeling dehumanized was one of those categories. And this kind of picks that up, that you're just like on a factory belt, going along and not feeling like people are really listening to you. So there's some of the themes around those negative comments. And some of you may recognize these when you have supported women in a standard fragmented model where they've not known their midwives. I think in your community-based models, such as the Puskismas and the private midwives, this is less likely because they're recognizing the midwives that are caring for them. Okay, next slide, please. However, when we then looked at the comments for the continuity models, so that meant when they saw the same midwife throughout in the public hospital or at home, or if they saw the same doctor, if they had a private doctor, maybe in a private hospital, and they saw the same doctor, that this is where it was really different. And for a private doctor, it was about 60% positive comments. And so that means about 40% negative, so a big change already. And the same with the midwifery continuity of care in the hospital, which was around also about 60% positive, 40% negative. However, the biggest change we saw was when we looked at those that had the same private midwife, similar to your TPMBs. And this is where they would have the same midwife who would do their appointments in their home or in their clinic, and then be there at the birth, usually at home, but sometimes these midwives have rights in the hospital, so they can do a birth in a hospital. They had 96% positive comments. That's very different from 86% negative. Can you see the flip? Here we have a model of care that really works for women. But so few women have this access in Australia. So some of the things that they mentioned that was really, really helpful was that deep trust between the woman and the midwife. So if a complication occurred, they really trusted the midwife as well. But there's also the ability to have your past trauma healed through that relationship, through being able to constantly touch base and talk about what is stressful for you, and to have that midwife know your previous birth experience story, what worked for you, what didn't work for you. So it was a very a healing experience with the same midwife with you. So can you already see the difference here? This is the power of listening to women. When we asked them, what was your experience? So many did not want the fragmented standard version. They really wanted the midwife who knew them, who trusted them, who helped them feel empowered. Next slide, please. So here's a little bit of a summary between the difference of the fragmented and the continuity of care. In that relationship, we have the difference of somebody potentially being judgmental or just not really seeing them as a person, through to a trusted advocate, somebody who knew their story and would stand up for them when needed. There was the information from being conflicting advice every single time to then a cohesive, evidence-based guidance. Then we have the autonomy, so women feeling that they're making their own decisions. But in the fragmented care, many felt that they were left without unanswered questions or with less decision-making. They felt the decisions were often made for them, especially in the case of induction, which we talked about last week. However, in a continuity, they really felt that this was woman-led decision-making, that the woman felt that she could make her own decisions and they would be respected by the continuity of care midwife. And then finally, the outcomes, the feelings of disempowerment, the things that we saw with the birth trauma last week. However, the opposite would be being confident about birth, being able to have the birth that you've chosen and that you've wanted, and having confidence that you can have that birth and be listened to throughout the whole experience. So there's a little bit of a summary. This is what the women said about their experiences. Next slide, please. Okay, so the next paper we looked at was another question, and we asked them quite simply, what would you do differently if you were to have another pregnancy? And this was such a fantastic question. We had over 6,000 responses. It's one of Hannah and I's favorite questions in the survey, because about 70% of the survey respondents answered these questions, and we had 6 main categories of their comments. Next slide, please. Next slide, please. These are the main categories. First time, they talked about wanting to be ready next time, and there was a lot of self-blame in that, but they wanted to get more educated. They wanted a particular birth experience. I'm going to go through these in a bit more detail. The type of model of care they wanted, and better access to what they want. And then finally, some said they didn't want to change anything, and some said they didn't want to have another pregnancy. So that's kind of how we grouped all those comments into the different categories. Next slide, please. The next time I'll be ready. This is a majority of women said something about next time I'll be ready. And this was feeling that they want to make different choices and maybe they weren't prepared well enough last time. I sometimes feel a little bit of sadness with this theme because they take it on as a self-blame. The women say, I wasn't prepared enough. And they don't feel that they got that from the healthcare providers, the midwives and the doctors. And so next time, they don't want to rely just on the information they may be given. They want to get that information themselves and be ready for their next pregnancy. Yet they blame themselves for not being ready enough. The next thing they talked about in the better experience was the type of birth. We're often told in Australia that women are choosing more and more cesareans because they want it. But we didn't find that in our big survey. What we found is that the majority of women want to have a vaginal birth. And a lot of them wanted to do that at home. And a lot of them wanted to do that after a previous cesarean. So they wanted a VBAC. And then they wanted a specific model. And guess what model they wanted? You're right, midwifery continuity of care. They used all the right terminology and they described that they want to have the same midwife throughout pregnancy, labor and birth, and in the postnatal period. They're really clear about that. That was the biggest one they wanted. Very few of the specific experience group wanted a cesarean birth. A very small proportion said they wanted a cesarean birth. The large proportion wanted a vaginal birth. And the same with the model of care. The largest group wanted a midwife, and a small amount wanted to have the same doctor. And they often had reasons for that because of high-risk reasons. Okay, next slide, please. So what do they really want? If I kind of had a list that I put together, I've kind of listed them here. First of all, they kind of blame themselves. They blame themselves that they didn't get educated enough. So what can we do as midwives? I think we can lift that blame and say, it's not your fault. Maybe we didn't support you enough. Maybe we didn't educate you enough. Because I think that's part of our role as midwives, to be the educators, to be the people that advocate for women, so that they don't come out blaming themselves for not knowing enough. Then we need to really recognize the value of vaginal birth. And I think you do here in Indonesia. And certainly the TPMB that I went to with some students yesterday, the women in that area really want to have a vaginal birth. And they all don't want to go to hospital if there's a problem because they don't want to have a cesarean birth. But in Australia, we're kind of shifting our narrative and saying all birth is equal, it's absolutely fine, and cesarean birth is fine. But this is not what women are saying. When women are reminding us to have value and to respect vaginal birth. They want a midwife throughout their entire experience, including birth. We have to be mindful in Australia because we've got a rise of models where the continuity does not include birth. And that's not what women are asking for. They want access to home birth. That might not be something you do in Indonesia, although you have the TPMB places that look like home. They feel very homely. But women in Australia wanted to have that access because they don't have the middle ground. They either have hospital or hospital, and maybe very few birth centres. They want to avoid interventions. If they had an induction, they do not want that next time. They want to avoid the interventions. And they often blame themselves for taking the interventions in the first place, or saying yes to them, or feeling like they were encouraged to say yes without being given another option. And they want equity. As you may know, Australia is a very large country, and most of us live along the edge. But for the people that live in the middle, they don't have the same access as those of us on the edge to maternity care services. And those in the middle said, that's not fair. Next slide, please. So really, if I was going to kind of summarize about what women wanted, especially about their model of care, they really desired that spontaneous labor, intervention-free labor, vaginal births, and environments that actually support physiological birth rather than expect women to have interventions. And they want the midwife who understands their preferences, acts like a shield, advocates for them, and has ideas against interventions and has different suggestions, like using the gym ball or the birth ball that you have here. Let's move on to the next slide. So the last subject I want to talk about is debriefing. And I'm not sure what the Bahasa Indonesia word is for debriefing, if it's something that you really think about. But in Australia, we see it as an opportunity to talk to the woman and have the woman be able to explore how she feels about her birthing experience. And we often provide it for women who've had a traumatic birth, but sometimes that's the clinician that's decided that that woman had a traumatic birth. But we had another question in the survey where we said to women, tell me about your experience of talking to somebody after your birth. And what we could then find out was what was helpful and what was unhelpful when women were having that experience of talking to somebody. So we know that this is important because 1 in 3 women are experiencing a traumatic birth. And then we also know from the World Health Organization, 13% of women experience mental health postnatal issues. So what is debriefing? Debriefing is when the woman and whoever they see, whether that's the doctor, the psychologist, or the midwife, has that opportunity to talk and has the ability to have their questions answered. But when we looked at the helpful versus the unhelpful was quite interesting. Women said things like, well, once the baby is born, I don't matter anymore. That's not okay. They described experiences in the hospital where the midwife would come in and look at the baby and check the baby and then would say to the woman, are you okay? How are you feeling? And one woman said, I feel terrible. And the midwife said, oh, okay, and continued looking after the baby and walked out the room. She just said she needed help, and then she didn't provide it. And then having clinicians who felt defensive. So what I mean by that is the woman would ask questions like, well, why did I have to be induced? Or why did I have to have that cesarean? And the response coming back from the midwife or doctor was, well, you're just lucky I was there because I saved your baby and it had to happen. And not really explaining it in a physiological way or a way that the woman could understand the actual reason for it. They just get defensive. And then the highly dismissive phrase that we're very used to, well, at least you have a healthy baby. You might be emotionally broken, but you have a healthy baby. But that's a very low bar. We need to move beyond that, because if we don't have a healthy mum, who's going to care for that healthy baby? But the helpful things were things like the opportunity to ask questions and actually explore what happened to them. And that can also, because when you're in labor, time is distorted. This happens, then this happens, and this happens. And it's hard for women to put it into order. And the debrief can be a way to process that. The woman says, but this happened, then this happened, then this happened. And the midwife or doctor can say, oh, that's interesting. But what actually happened was this, then this, then this, then this. Ah, that makes more sense now. The validation, I'll just go back one, the validation of feeling that they've been listened to, how important that is to be listened to. All right, we'll stay on this one. The next thing we got from the comments was, well, when should we debrief? You know, should it be a magic point at 10 days post-birth, every woman should get a debrief? We didn't get that answer. Why? Because every woman is different and every birth experience is different. Some women said day 1 or day 2 was not the right time to have this conversation, especially if they'd had a cesarean and they were on strong pain medications. They can't even remember what happened in that day. And then for some, in those first few weeks after having the baby, they're still in shock, or they're still not able to process it. Or maybe they're really, really grateful at that point and they're not being able to think about what happened. Or maybe they've had no sleep because they've been up breastfeeding all night. So it was trying to have a debriefing that can be flexible and highly individual. And this is where continuity of care can really help, because you have that longer time. You can touch base with women and answer the questions. And often it's not just a one appointment fixes everything. It's lots of different times to talk about how they're feeling. But it's got to be when the woman is ready. And so as midwives, and we see a woman and she's no longer going to be in our care, maybe she's being discharged, we need to think, well, maybe she is not ready yet, and we need to let her know where to go when she is ready. In Australia, we need to let her know how to access psychological support or what kind of child and family health services are there. And the same here in Indonesia. Who could they talk to when the time is right? And give them that option. Okay, next slide. So really, if we connect all those dots, what is it that we're connecting there? We're connecting the importance and the power of midwifery. First of all, that model, that continuity of care really establishes that deep trust. And in Australia, we offer this in the hospital. Not every woman, but that is the dream. So in Indonesia, how can you offer these models of continuity of care with a midwife in a hospital? in the Puskesmas and you already offer it in your TPMB. And that goal to really understand what is it that the woman wants. Ask the question before she's had the baby instead of afterwards like we did. What is it that you want? What are your goals and your dreams for this birth? And then support her to achieve them as much as possible. And then finally, the opportunity for healing. To be able to offer those conversations, the debriefing conversations, in a safe way, in a way that the woman feels that she's being heard and not dismissed, and that she's being treated with respect and not disrespect. Next slide, please. And I guess I'm giving you a call to action that you can then lead that change in Indonesia. Advocate for continuity, not just in the community, but at all levels of your healthcare. Where is it? And where can we increase that? And then when you're doing debriefing, validate rather than defend. Say, it's okay, I hear that you're upset. I can hear this, and I'm going to listen to this, and what can we do to make sure that wouldn't happen to another woman? And make that kind of debriefing available to all women. We had women who had a positive birth experience, and they still said having the opportunity to debrief was really good, because then I could see why it was so good. Okay, next slide, please. All right, so your quick ticks. These are, fragmented care can, for the women that we've looked at in Australia, and actually from our other data in the Netherlands, can create trauma and confusion. And the opposite with continuity of care, that can be healing and empowering. Women want to be informed, respected, and supported towards physiological birth. Let's focus again on how important physiological birth is for women. And then that debriefing. It is really important for women's mental health, whether or not they had a great birth or a traumatic birth. And then actually you as midwives and our profession as midwives, globally, Australia, here, across the globe, we really hold that power to make sure that the mother means just as much to us as the baby does. My exciting news for you all is that we have the Best Indonesia study. The survey is open right now, and we want to get this data, but in Indonesia. So you've all got access to women who've had a baby in the last 5 years. That's all they need to have done in Indonesia. We want you to share this QR code, share this link to women all over Indonesia so we can hear their experiences. What's it like for women in Indonesia right now, birthing? If we can hear from them and then we can tell our leaders, then we can make more change. So it's live right now, and we've got some flyers that you can take away with you as well after this webinar that you can share and share with women so that they can do this survey. The more women we hear from, the more voices we will hear from, and the better change that we can make. And this has been led by the amazing Dizza at University of Erlangen. Okay, next slide. And stay in touch. If you want to learn more about the Birth Experience Study, we've got our own website, thebirthexperiencestudy.com. Or if you want to follow me, that's my Instagram. And that's where I share all the research, plus some photos from our trip. But thank you so much for listening today.
Ladies and gentlemen, let us give another round of applause to Dr. Hazel Keedle for that insightful and meaningful presentation. Dr. Keedle, thank you for such a rich and thought-provoking session. I believe we can all agree that your presentation has highlighted how evidence-based antenatal care is not only about clinical precision, but also about delivering care with empathy and understanding from the very beginning of the maternal journey. Alright, kesimpulannya dalam bahasa Inggris Dalam bahasa Indonesia, mohon maaf teman-teman, evidence-based antenatal care itu menekankan pentingnya continuity of care dalam praktik kebidanan. Model ini membangun kepercayaan perempuan terhadap tenaga kesehatan dan meningkatkan pengalaman persalinan yang positif. Banyak perempuan yang saat ini menginginkan edukasi lebih dalam tentang pilihan seperti feedback, persalinan pervaginam, dan menghindari intervensi yang tidak perlu. Mereka juga mengharapkan layanan yang adil, pilihan yang luas, serta pendekatan yang berpusat pada kebutuhan individu. Hal ini membuat peran bidan menjadi krusial karena mampu memberikan asuhan yang berkesinambungan dan personal. Continuity of care memungkinkan bidan memahami kondisi, preferensi, dan nilai perempuan secara utuh. Debriefing pasca persalinan seperti tadi yang sudah sempat dimention menjadi bagian penting untuk memvalidasi pengalaman, memproses trauma, dan menjaga kesehatan mental ibu. Pendekatan ini harus dilaksanakan dengan waktu yang fleksibel dan tidak memaksa, karena setiap perempuan memiliki proses yang berbeda. Yang tadi disampaikan adalah dari week 1 sampai week 6. Kemudian di Indonesia, bidan dapat menjadi agen perubahan melalui advokasi komunitas dan pendekatan yang lebih empatik. Validasi pengalaman perempuan perlu diutamakan dibandingkan sikap defensif terhadap intervensi. Kesimpulannya, dengarkan keinginan perempuan, tawarkan continuity of care, dan jadikan debriefing sebagai standar wajib dalam pelayanan kebidanan. If I might briefly reflect, one key takeaway is how recent evidence continues to reshape the way we approach antenatal care, making it more responsive, more personalized, and ultimately more compassionate, right? Yes, we have finally arrived at the session that many of you have been waiting for, everyone. Yes, this is the moment where we open the floor, exchange ideas, and explore the topics more deeply together. For our on-site participants, if you would like to ask question, please raise your hand. Yang mau bertanya, silahkan diangkat tangannya. Our committee will come to you with a microphone. Kindly introduce yourself briefly, your name and affiliation. Jadi nanti perkenalkan diri ketika bertanya, kemudian sampaikan asalnya dari mana, and keep your question concise so we can accommodate as many participants as possible. And then for those joining us online, you may submit your questions through the chat box or raise a hand emoticon. I do believe there is an option to use it. Our team will help filter and relay them to us here on stage. Jadi yang di dalam Zoom, kalau ingin bertanya langsung ke Dr. Hazel Keedle, boleh langsung type di chat box-nya, atau nanti boleh pakai emoticon hand yang raise hand itu. Terus, and as a small token of appreciation, we do have a souvenir prepared for participants who actively engage in today's discussion untuk yang on-site. So do not hesitate to take part. Your questions are very much welcomed, and in many ways, they are what brings this session to life. All right, ladies and gentlemen, the floor is now open. Boleh, if you have a question, this is your moment. Please make it visible. Raise your hand for those on site. Anyone? All right.
Okay, morning Hazel. Terima kasih atas ruangnya untuk pagi hari ini. Terima kasih, saya Aida Husnul Hatimah. You can call me Aida. I'm a doula of Dona and midwives in Surabaya. Mungkin saya bahasa Indonesia saja supaya lebih nyaman ya Mbak ya. Terima kasih. Dalam beberapa hari kemarin, kurang lebih 2 minggu kemarin, saya mendapati ada satu ibu yang ingin melakukan 2 VBA2C, twice of feedback in 2 cesarean. Ya. Dan ternyata si ibu ingin melahirkan di Bumi Sehat milik Ibu Robin Lim di Ubud, Bali. Jadi dalam perjalanannya mendapatkan ACC dari dokter Objin di Bali, alhamdulillah terlaksana dalam perjalanannya 2 feedback dengan perjalanan fase laten dalam 2 minggu. Lalu dalam fase laten itu ibu seperti denial, tidak mengharapkan persalinannya itu dengan dokter, tetapi tetap di Ubud, Bali. Dan puncaknya sepertinya akan terjadi debriefingnya di fase aktif sampai fase mengejan. Kurang lebih hanya terjadi dalam 3 jam, tetapi dia meraung-raung seperti orang, mungkin kalau di Indonesia bilangnya seperti kesurupan gitu ya. Ternyata di dalam fase itu dia bisa mengeluarkan semua energinya, semua traumanya dalam persalinan sesar 2 kalinya, dan mendapatkan persalinan yang sangat nyaman dengan upright position. Lahir dengan 3.900 gram berat badan bayinya, dan bayinya lahir dengan sehat selamat tanpa robekan. Jadi sepertinya saya sangat bahagia di dalam perjalanannya. Oh, ternyata dalam 2 minggu perjalanan ini sepertinya mendapatkan cukup keterbukaan dalam ibunya. Tetapi saya sangat menyayangkan ketika mungkin ada beberapa dokter yang tidak mengizinkan isi ibu menginginkan perjalanan VBA 2C-nya itu dengan nyaman, sepertinya seperti itu. Jadi saya sangat bahagia mendapatkan perjalanan ini. Mungkin bisa share ke Hazel, apakah memang benar dalam perjalanannya itu dia sudah debriefing in 4 years past, tapi kok ternyata dia tidak selesai di dalam perjalanan 4 tahunnya kemarin, tetapi dia selesai di dalam perjalanan, dalam persalinannya saja, dan setelah persalinan dia langsung, oh ternyata aku adalah ibu yang berdaya, seperti itu. Terima kasih atas izin waktu dan tempatnya.
So thank you so much for the, probably this is called discussion, not a question. So Dr. Hazel, she says she meets this mother who has already gone through cesarean 2 times, and then she wants to take feedback. And when she wants to take the feedback, she wants to go to the Bali, meeting Mother Robin Lim, if you're already familiar with her. And then Mother Robin Lim is very, very much prefer a normal birthing even after cesarean. That's why. And then for the 2 weeks journey, the mother is, I can't say something like she is going through it comfortably, but then when she is birthing, she is becoming something crazy, like screaming and stuff. But then the mother says after birthing normally, she says, oh, I got it, I like this. We're calling it debriefing, right? Before this, so she says after 2 cesareans, her debriefing time is not done yet. But she says after this one time vaginum birthing, she says my debriefing is done right here, something like that. Yes, probably something like depression or something like she finally says like, oh no, I'm a powerful mother. Before I can't birth my baby normally, but then after I birth my baby normally, now I feel like I am something like true mother and something like that. Yeah, something like that. So this is probably her third babies. Yep. And then probably one thing that I want to say, these ladies also say that most of the doctor this patient met really against her feedback option. That's why she goes to Bali, and then she gets support from that, and that's what happened. So she just wants to share it to you and probably get some feedback of yours. I have no idea.
Well, thank you for sharing that amazing story. And one of the joys I have is that every week I have women who've had a VBAC or had a better birth after cesarean contact me and tell me their stories. And it is amazing. And then I also get women who contact me and say, you know, I've had 2 cesareans, I've had 3 cesareans, can I have a vaginal birth, like asking my permission? And I say, well, you know, you can read the book, you can check the research. Your biggest challenge will be to find support. And so obviously in this woman's experience, she went and found the support from Robin Lim over on Bali, and I know about her birthing center. And then she had that experience and felt amazing. And that's certainly something that is very common amongst women who've had that opportunity. And I think it is the experience of having it through your vagina, but it's also the experience of being heard, of being respected, and being given the option to have the birth that you want. And it is very, very powerful. But here, as in Australia, the challenge is to find the support who will support you to do that. And it's really after 2 cesareans, there's not much of a difference with uterine rupture rate from 1 to 2. It goes up a little bit after each one after there, but none of those equal 100% uterine rupture rate. There's always an element of a risk. Nothing ever equals that you will. So it is actually for the woman to be happy with that. The woman's got to be aware that there is a chance that she can have a uterine rupture, and what that might mean for her in the location that she is in. And that needs to be important as well. If you're doing that at home or in a birth center, there may be a delay to go to the hospital for an emergency cesarean if that's what's needed. But again, that is up to the woman to see if she is happy with that, as long as she's been given all of that information. And as midwives, that is one of our jobs. We can't say to her, yeah, you've had 5 cesareans, everything will be fine, nothing will go wrong. Like, we have to give evidence-based information so that the woman can make the decision. And that goes through what the risks are, what could happen if there was a uterine rupture in the location that we're in, or that she's planning to birth in. What would that look like as well? And make that very clear to the woman. I've actually got a master's student doing a research project right now on the experiences of women who did have a uterine rupture. And it's really interesting because we've never actually asked them before. We've never sat down and said, what was it like to have a uterine rupture? And now we have. And we're analyzing that data right now. And it's really, really interesting and an important part of the puzzle. But thank you for sharing such an amazing story. And it fills my heart with joy to know that she feels so amazing and that her mental health is so much better after that birth as well. So thank you.
Alright, thank you so much, Dr. Keedle. So, jadi feedback dari Dr. Keedle adalah beliau juga ikut happy karena mendengar berita bagus itu. Kemudian banyak juga yang sebenarnya berbagi ke Dr. Keedle sama yang tadinya cesarean dapat feedback kemudian berhasil. Banyak juga yang berbagi ke beliau dan beliau juga tambah ada satu lagi nih. Oh, berarti saya happy banget gitu. Nah, kemudian tapi sebelum itu karena lagi-lagi cesarean mau feedback kan ada risiko, ada ruptur. Nah, itu dari awal sampai akhir, apapun yang terjadi risikonya harus dijelaskan dengan jelas. Jadi tetap harus evidence-based. Tapi apapun yang terjadi, karena kita midwife, kita juga harus pro dengan pilihan ibu. Kita harus mendengarkan, dan kalau misal kita melakukan itu, pasti juga dampaknya ke mental health ibunya tadi atau hal-hal lain yang juga memberikan hal yang lebih baik ke ibunya karena ibunya juga tadinya cesarean prefer ke feedback, something like that. Is it okay? Okay, thank you so much. So, because of the limited allocated time, we have to end the Q&A session for Dr. Keedle. Everyone, thank you so much for the participation. Dr. Keedle, before we let you go, may I ask, would you like to share any final remarks or short message for our audience today?
I think to remember that you might see some of the things that we share today and go, I can't make those changes. I can't do those things. But you can be that change for the change that you want to see in Australia. Way back when I had a vaginal birth after cesarean, just of my second baby, I never imagined that I'd be able to make the changes and support the changes that are happening in VBAC in Australia. And yet there is those changes that are happening. So think big. What is it that you want to do? What do you want your legacy as a midwife to be? And you can achieve it.
Thank you very much for that closing note. It certainly gives us something valuable to carry forward. Once again, on behalf of us, thank you, Dr. Keedle, for your time to today's session. We truly appreciate it. Ladies and gentlemen, another round of applause as we escort Dr. Keedle. We now forward to the next session of today's webinar, where we will continue exploring the continuum of compassionate, evidence-based care. Before we begin, may I once again invite all of you to turn your attention to the screen as we present the CV of our second speaker. I encourage everyone, both on-site and online, to take a moment to follow along, because it truly reflects the depth of expertise behind the insights we are about to hear. Now, ladies and gentlemen, our next speaker is someone whose work has played a significant role in shaping contemporary perspectives in maternity care. With years of experience in both academic and clinical settings, her contributions have influenced not only research but also real-world practice on a broader scale. It is my pleasure to introduce Professor Hannah Dahlen, a distinguished academic and researcher widely recognized for her dedication to advancing maternal and childbirth care. Hannah Dahlen is Professor of Midwifery, Associate Dean, Research and HDR and Midwifery Discipline Lead in the School of Nursing and Midwifery at Western Sydney University. Hannah is a leading midwifery researcher in Australia with an international reputation as an outstanding midwifery scholar. This is demonstrated through publication of over 200 papers and book chapters, despite only being an active researcher for the past 10 years and maintaining clinical practice, and has given papers at over 100 conferences and seminars since in the past 5 years, with half of these being invited national and international keynote addresses. Hannah's research interests fall under two major themes: keeping birth normal and health service or policy development. Next, please. She has been a co-investigator on the European Union grant cooperation in the field of scientific and technical research action project led from the University of Central Lancashire. In 2011, Hannah, along with Professor Donu from UCLN and Professor Holly Kennedy Powell from Yale University, formed an international research group called APIIC, or Epigenetic Impact of Childbirth. In 2019, Hannah was awarded a Member of the Order of Australia in General Division in the Queen's Birthday Honours List for her significant services to midwifery, nursing, and medical education. Hannah was named by November 30th, 2012 as one of Sydney's leading thinkers in the Sydney Morning Herald's list of 100 people who change our city for the better, and is probably the leading force promoting natural birth and midwife-led care in Australia. Hannah remains clinically engaged currently and has had a predominantly clinical career for her other professional activities. Like everyone with an extraordinary profile, it is always inspiring to see such strong blend of expertise, leadership, and commitment to improving care for mothers and families. Please next. In this session, Professor Hannah Dahlen will be presenting on the topic recent best evidence in intranatal care. This phase, as we know, is one of the most critical moments in the maternal journey, where knowledge, skills, and compassion must come together in real time. At this moment, I would like to invite all of you to warmly welcome Professor Hannah Dahlen to the stage with a round of applause. Please, we invite you to the stage, Professor. The stage is yours.
Thank you all so much, and salam alaikum. It's such an honor to be here in Indonesia and speaking to you again. I'd like to say a special thank you to Boyum, and a lot of the young people call her Umma, which I love. It means grandma. Maybe I'm a little bit old to call you Umma, but I feel like you are my Umma too. We met last year. We were in Jakarta together, and we were at the APKIN conference, and I learned so much from you, and it is a fantastic organization. So thank you so much for coming. So we've shifted things around a little bit because Hazel focused on the best survey. And last week I talked a lot about the best practice around intrapartum care. So today I'm going to touch on antenatal. I'm going to touch on human rights, and I'm going to touch on intrapartum by looking at some of the Indonesian practices and some of our midwifery guidelines. And I'm going to touch at the end on what are the things we need to do to make midwifery strong. And I'm going to look at the pillars from ICM. I'm going to look at some pathways forward. So next slide, please. I don't know about Indonesia. I have seen your boats. They are small and beautiful. But these big boats are more and more in the oceans today. These big boats have very big nets, and they throw the net out and they catch everything. They catch the tuna and the fish that they want to eat, but they also catch the turtles, the dolphins, the rare species, and then they throw them back. And what happens in this is that we take from the ocean not just what we need, we take from the ocean that which is also should be kept in the ocean, and we destroy our oceans. I use this analogy to talk about maternity care. So often in maternity care, we are not just treating those who need our medical intervention, but we are capturing many women who are low risk, and we are turning them into complicated births. Is that analogy translate okay in Indonesia? Yeah, so I call us the super trawlers of risk. Everything is risk, risk, risk. But what about the women who are not at risk? And how many women who are well and healthy are pulled into the net and have damage as a result? In Australia, we banned these. They are not allowed off our coasts. We said, no, go away. We need to say, no, go away when it comes to maternity care. Next slide, please. I love these little birds. I am this one. Always seem to be looking in another way, causing trouble. That's my favorite bird, going, I don't think so. So the interventions that we use to treat obvious complications, arming the sick with good equipment, we are more and more using for women who are unlikely to get a benefit from. Yeah? And we are alarming the healthy. And we are even harming them. We are harming the healthy. I know that there are some significant risk factors, and I know Indonesia has a high maternal mortality rate that you want to reduce. But are there better ways to do it? And are we doing it the best way? Next slide, please. This is from one of my favorite books called Reading Birth and Death by Jo Murphy-Lawless. And what she says in this book is, if I were to extract only 2 words that would classify the concerns of contemporary obstetric practice, they would not include birth, but risk and death. When I taught my children to ride a bicycle, I learned very quickly not to say, don't hit that wall, don't do that, don't go there, don't, because they would look at it and they would go to the wall. I learned to be very careful. We are creating a problem where we are turning women into risk and death and not necessarily giving them the best support to direct them. Next slide, please. So I want to focus a little bit on the antenatal care for a positive birth. Last week I talked about intrapartum care for a positive birth, and this is the WHO 2006 guidelines. And what I want to point out is the word positive. Yeah? What is that in Indonesian, Farida? Positive. What is the Indonesian word? Positive. Oh, positive. Yay. So we want positive care. We want safe care, but we want positive care. Next slide, please. So these are the guidelines in the antenatal care WHO guidelines that yes, pregnancy related preventable morbidity and mortality is unacceptably high in many countries. However, the WHO guidelines are about improving the utilization of health and the quality of care. And we must expand the agenda to prioritize putting the woman at the heart. If you provide good clinical care, but it is not humanized or not respectful, women will not come for your care. Yeah? In Australia, we have women who are now birthing with no one. Why? Because they are scared of what we will do to them. We are in a country with some of the lowest death rates in the world, and we have women who are staying away from our care. That is so sad. So our care must be humanized. We need to maintain normality. We need to preserve physical and sociocultural normality. We need to promote a healthy pregnancy. We need to, yes, treat risk, and we need to also reduce illness and death. But we need more than that. We need to also facilitate a positive experience and transition into labor so they're prepared. And we need to prepare the mother and the father and the family for parenting. You know, as you know what it's like, you have your first baby and everything's the birth, and then you're holding your first baby and you're like, why didn't anyone tell me this is where the trouble starts? This is where the hard work starts. So how do we prepare women to be strong mothers into the future? Next slide, please. So prior to 2016, WHO had recommended that 4 antenatal visits were enough. Then they did a very big study, and they actually showed that 4 antenatal visits were too little. And so the recommendation went to being 8 antenatal visits. And they actually showed that there was an additional 8 per 1,000 deaths with the lower rate. The higher rate of visits did improve those outcomes. But what has moved on from the first guidelines is not just about clinical episodes. You come, you have your blood pressure, you have your glucose test, you have this, you have that. It is now focusing on positive. It's now focusing on what does the woman want? How do we connect with the woman? How do we find out what she wants? And how do we offer psychosocial support? And so these are the changes that have occurred. The additional visits benefited the low and middle income countries more than the high income because of the underlying health issues, but it had a significant impact. Next slide, please. So you can see that that 8-visit journey has an increasing intensity when the risk escalates, more visits, but also when women are approaching the end of the pregnancy, more visits. And once they get to 41 weeks, as we discussed last week, that is when we should be having a discussion about induction of labor with women. If women have got complications, we should be having more visits, correct? The problem is we give everybody the same. I've never understood why the primate, who has lots more questions and concerns, gets exactly what the multip gets, who might feel, okay, I know what I'm doing. Everybody needs to be treated as an individual. Next slide, please. So we know we do need to do the clinical, but we also need to now be very focused on the psychosocial and the environmental. So of course, in Indonesia, anemia is a big problem, correct? Anemia. So this is going to be a big focus for you. When I look at your maternal deaths, I can see your 2 big issues that need to be addressed are anemia, hemorrhage, because if you bleed and you're anemic, you are much more at risk than if you bleed and your hemoglobin is good or your ferritin is good. And hypertension, preeclampsia. 2 big things. So then our focus must be on making sure that women are in the healthiest state with their blood and in the healthiest state with their blood pressure. We also know asymptomatic bacteria, making sure that there is no underlying urine infection, can reduce preterm birth. And we know that HIV, syphilis, TB, screening where there is high rates of TB are also things that can make a very big difference. But how many women in Indonesia get asked about whether or not they are in a domestic violence relationship? How many women get asked about their mental health? How many women get asked about how their support is at home, what their stresses are? These things shape health and we must focus on them. How many women get asked about substance abuse, not just cigarettes and alcohol? I know alcohol is very low in Indonesia, but what other herbs are they consuming? What other things we don't know about are they consuming? Next slide, please. So we need to encompass the whole person. The other thing is ultrasounds. Ultrasound is an extremely good tool for helping us date the pregnancy if there is any doubt. And that stops us inducing earlier or in thinking the baby is older than it is. It's also very good for detecting abnormalities and it's very good for detecting the growth. However, we do far too many. WHO recommends 1 early ultrasound in the first 24 weeks, 1. Now, I know many of you would have an early dating ultrasound, so do we in Australia. Many of you would have a morphology ultrasound, so do we in Australia. But what we are seeing more and more of that is not evidence-based is a late trimester ultrasound. If the baby is growing well, if everything's healthy, there is no need for another ultrasound as well. Why is this a problem? Because we still don't know what we're looking at. Small babies often underdiagnosed, poorly diagnosed, and big babies, as we talked about last week, 60% of babies induced for being big are not big. So our hands are still important. Our measuring tape will be here for a long time, our clinical skill. And that is all done so much better when you have continuity of care, when the same midwife is seeing you week after week after week. And she puts a hand on you and she goes, maybe this baby hasn't grown as much as I would expect. Very different when you see a different person every time. But we know that having 1 ultrasound in that first 24 weeks, it's good at estimating the age because the later it is, the worse it is at estimating age, detecting abnormalities, reducing early induction of labor. And also, we do know women do like to see their babies. Sometimes it does help them with the connecting. Next slide, please. So, for antenatal care, like with intrapartum care, it is about putting the woman in the center. The woman is at the heart. The midwife-led care surrounds the woman, but this is where I want to say Indonesia is excellent. I want to say your cadres, your community support, the way that you work with that true primary healthcare model in the community is excellent. So your cadres are exactly what WHO now recommends we engage with. And they are trusted community members who are good at educating on health behavior, on eating, on saying you need to go to the hospital, connecting people. So you are actually in Indonesia very good at this task shifting, the cadres. I would love to see more continuity of midwifery care because you have 67% of women in Indonesia are cared for and birthed by midwives, 67%. And you have so many midwives. You really do have a lot. And we need to put the mother in the heart of the center of this care. Next slide, please. So bridging the gap between the clinical and the community, I actually think Indonesia is very good at. It probably better than I have ever seen other than the Netherlands. Women-held case notes are a really good way of having that communication between people. Carrying their own notes, we now do routinely in Australia. But what you do so well is this community mobilization. Yeah, your cadres are so powerful. It's crucial for rural areas. It's crucial for low resource areas, and you do this very, very well. Next slide, please. Right. Now I want to talk to you about some things I've learned in Indonesia, and I want to have a discussion with you, and I want to do this very respectfully. Because as I said, this is how I describe Indonesia. You have a very good foundation, your primary healthcare. Very, very good. You have very good walls from your house coming from your foundation. What we now need to do is make sure everything inside there is very, very good. In Australia, we have a very, very bad foundation. We have walls that come from the foundation that are rigid, and we have a beautifully decorated house, but the structure is a problem. Your structure is good. We now need to decorate the house. In Australia, because we have it all built and we went so medicalized, we have to put on more rooms to the house. You don't have to put on more rooms to the house. You have a good foundation. I have heard so much about the 6 hands at birth. When I went to Bangladesh recently, it was very big in that place. It was stopping private midwives having births. It was increasing women going to hospital. It was reducing that amazing foundation you have of primary healthcare. So I am a researcher. Whenever I hear something like that, I start to search. And I go to Diza and I go, where did this come from? And she helped me. And so I want to talk a bit about this. Next slide, please. Next slide, please. Great. So if I'm correct, this comes from this document. It doesn't say 6 hands at birth. That is the local language, yeah? It says that there should be at every birth a doctor, a midwife, and a nurse. What it doesn't say is what kind of birth you need that at. It doesn't say for high-risk women, which I would agree. It says all births. This is the first problem. All births with 3 people in the room, particularly the doctor, is a really misuse of resources, okay? I don't understand the nurse. We should have 2 midwives. 2 midwives and a doctor if there are problems. There's no risk stratification. There's no saying for who this should happen. It's all people. To mandate a doctor at every birth, regardless of risk level, when midwives attend so many births and you have a physician shortage, particularly in rural areas, is not common sense. Okay, so let me now look at the international evidence. I'm not just speaking as someone who's never heard this before. I then went and I looked at all the international documents. Next slide, please. Let's look at what WHO says. Let's look at what ICM says, and let's look at what FIGO says. Okay, WHO says midwife-led continuity of care is recommended in settings with well-functioning midwifery. So my call to you is the midwifery education, which is excellent in Erlanger, needs to be excellent everywhere. There needs to be standards where you can hold your head up as a professional midwife and say, I am trained to the international standards. I am an autonomous, competent midwife. The second thing WHO says is that when you increase medicalization in birth, you undermine the woman's capacity and her experiences. The third thing WHO says is that the doctor's involvement should only be on clinical indication. This is what's different in the Indonesian regulations. It's all women. WHO says where you need to have them. What does ICM say? That is the International Confederation of Midwives, which is my professional and your professional leading body in the world. They say normal birth is the midwife's scope of practice, autonomous scope of practice. They say women should have access to midwife-led care with one-to-one support from a midwife. And they joined in 2019 with UNFPA to say that all midwives must work to their full scope. And if you work to your full scope, then low risk, normal labor and birth are the midwife scope of practice. What does FIGO say? Does everyone know FIGO is the head of the obstetricians in the world? Yeah. FIGO says a second trained attendant in second stage is a good thing, but they do not say it must be a doctor. They do not stipulate a doctor. They say obstetricians and midwives should work together with the doctor involved based on clinical need. Again, this is not what is in the 6 Hands document. And they say routine doctor at all births is not recommended. This is very important for you midwives to know this, because this is how you can challenge policy and say, okay, where is your evidence? Why do we do this? Could this be harming women? None of the international bodies support a doctor at every birth. And when I think of your excellent system, your excellent foundation, your excellent walls, don't decorate the rooms badly with this, because you have so many good things. When I went to the private midwives yesterday with our students, you have a golden gift in Indonesia. Your TPMBs, they are a golden gift. Do you know, in my country, we got rid of them all, and we have fought and fought and fought to bring them back. So don't let that die out. Next slide, please. So if we look at the 6 Hands next to ICM, WHO, and FIGO, you can see that Indonesia says the midwife really should be supervised by the doctor. But that's not what WHO says, or ICM, or FIGO. They say we're autonomous. If you look at what they say about the doctor, they say that they should be at all births, but all of the other bodies say no, only as needed. If you look at why this is happening, it's medico-legal risk management and accreditation compliance. But with clinical evidence, with well-trained midwives, and with risk escalation, we know outcomes are excellent. The second attendant at the birth does not have to be a doctor. The second attendant at the birth ideally should be a midwife, or if there is not another midwife, a nurse, or if there are complications, a doctor. The system in Indonesia it's restricted by this doctor dependency, and it interrupts the full autonomous scope of ICM's definition. The high presence of medical professionals in low-risk pregnancies will only increase intervention, which is opposite to what we should do. And the last thing is, it makes it unsustainable. Your doctors will fall over, having to run into all these births they don't need to be in. And it doesn't allow the midwives to build in their strength and autonomy and skill and practice. Next slide, please. I now want to look at human rights. And I want to look a little bit at some of the laws that are out there. These things help you with your fight. Next slide, please. What does the law say about women's human rights? These are the frameworks, and I encourage all the students in the room to take a photo, because a lot of people do not know the power behind these laws for the world. We have the Universal Declaration of Human Rights. Every country is a subscriber, including Indonesia. The right to life, the right to dignity, and to the highest health standard. CEDAW is the collaboration on a convention to eliminate all forms of disrespect and abuse for women. Indonesia is a signatory. This body looks at discrimination, over-medicalization, and lack of consent. Then we have some of these other incredibly important laws which look at freedom from cruelty, inhuman, degrading treatment, and also safe pregnancy and birth as a human right. And WHO, of course, recommends respectful maternity care for all women. We also have the rapporteurs. We have the rapporteur, special rapporteur on torture in 2016, and we had the special rapporteur report from the UN in 2019 that said obstetric violence occurs in every country in the world, and we need more respectful maternity care. So Indonesia has ratified several of these laws. They have international treaty obligations. So when you are having your discussions with the Ministry of Health, ask the question, how does this violate our international treaty obligations? And get friends with lawyers. One of my best friends is a lawyer. She wrote a book with me called Birthing Outside the System. Lawyers are champions in this area. Next slide, please. What is informed consent? This is so important. That the information is given, it's accurate, it's comprehensible, it tells you the risks and the benefits, and you freely agree or you say, no, thank you, and that is it. That the adult must have the capacity, and being in pain in labor does not mean you're not got capacity. There are almost no cases where women as adults with competent mental status are not able to make a decision about their bodies. And every new intervention needs to have a consent process. And the big case in the UK, Montgomery versus Lancashire, put this now as a benchmark law that all risks to a reasonable person that they'd want to know need to be explained. Next slide, please. And here's Indonesian laws. You have some very good laws. I was really impressed when I started to research this. You've got the human rights laws about the equality for all citizens. You've got rights around dignity and non-discrimination. You've got health rights, defining health comprehensively. You've also got regulations on reproductive care and consent, all built into your laws. You've also got a new law which covers the first 1,000 days of life and expands maternity leave. America doesn't have that. And you have got laws around all of that maternity leave and protection to ensure a safe birth. So you actually have some extremely good laws in Indonesia. Next slide, please. So what are the key messages from this? Informed consent is a human right. It's not an administrative task. I often hear midwives and doctors say to women, we are going to give you this test. Yeah? Is that informed consent? No. So when discussing a glucose test, I would always sit down and say, the standard recommendation is for us to do a glucose test at this gestation. What that will do is challenge your body and see whether or not your body may be not processing the glucose as well, and that could be an indication of gestational diabetes, and that could impact on the size your baby grows and some other things. Let's have a discussion about what this means to you, how important this is to you, what are the alternatives, and what are your thoughts? That's informed consent. And then if they turn around and say, yeah, no, I really do want that. I have a history of diabetes, fantastic. If they turn around and say, I am an athlete, I am 24, my BMI is normal, I am healthy, no, thank you, that is their right. Non-consented care can constitute cruel, inhuman, or degrading treatment under international law. Providers face legal and regulatory and workforce consequences if they don't adhere to these rights. Indonesia has a good developing legal framework. Though there are some gaps, you still have a very good framework. And this is important. If we normalize disrespect and abuse, we hurt ourselves. There's nothing worse than working in a work environment where we feel we have done a bad job. That leads to burnout, that leads to people leaving the workforce, that leads to women having less care. Next slide, please. I want to show you now some guidelines that we have had in publication for 20 years in Australia, but we've just released the last 5th guideline. I've worked on these guidelines with a fantastic group. We went around Australia. We had obstetricians, midwives, psychologists, everybody involved. And they have just been endorsed by our College of Midwives and our College of Obstetrics, which is fantastic. The obstetricians have put a stamp on it. Next slide, please. This is what we do in Australia. And I think that Indonesia is primed at a very good part in their growth. My call to you would be develop your own professional clinical standards. You drive your agenda for midwives. We have all care divided into level A, low risk. This is midwives' domain. They discuss things with the woman. They can talk to other people if they want to, but the care remains with the midwife. B, okay, we now have a risk factor. So let's say VBAC, because we've talked about it. B, you might want a discussion with an obstetrician about this, but the care remains with the midwife. But they collaborate. And C, now let's talk about triplets. I don't know about you, but I don't want to be on my own at home with triplets. This is when we need the obstetricians. The obstetrician takes the lead, but the midwife stays, involves, and provides that supportive care. So rather than just saying everybody needs this, we create the levels. But, and this is really key in our document, every single time the woman can say, thank you, but no. If she refuses to consult with a doctor, she does not get punished. She does not get not funded. She does not get care refused. We document she did not want this. We told her what was evidence-based, and we continue to provide the care. That is informed consent. Next slide, please. So at a glance, you can see A is the midwife's domain. Everything stays within the midwife's domain and is documented. B is when you consult, and the midwife and medical practitioner will consult, but still stays very much within the midwife's domain, but working with the obstetrician when needed. And C is where we need full referral, but the midwife stays involved, but the obstetrician takes the lead. This is for very high-risk things. This is for triplets. This is for twins. This is for cardiac complications. This is for eclampsia and preeclampsia. Then we want our obstetric colleagues, don't we? I want them in the room when this stuff is happening. Next slide, please. So the guidelines in Australia are focused on being woman-centered. The woman's at the center, informed choices are at the center. They focus on collaboration that's respectful, genuine, and sees each other as an equal. They focus on safety and quality and escalation with clinical risk. They focus on autonomy and consent. At any point, the woman can say no. They focus on documenting all your discussions. And they focus on midwives practicing within their scope of practice. And I think if we can really do this well, we make midwifery and maternity care and obstetric care not only safe, but the best quality. Next slide, please. Okay, this is the QR code. If anyone would like to read the guidelines and download them, they're freely available. I have sent them to DISA, but I would be so happy to work with you on working together to create some midwifery guidelines for Indonesia. One of the things that struck me in my travels around is your risk checklist. I think there are things on that checklist that are very out of date. They're not evidence-based. We update these guidelines every 3 to 5 years. They have to be based on the highest level scientific evidence. There are some things in your checklist that I think have not changed for many, many years. An example that surprised me was a miscarriage. A miscarriage puts women into a different risk criteria. Why? 50% of women have a miscarriage. We say 3 or more needs consultation. So some things need to update. Some things probably need to come in. We talked about underweight and overweight, and that wasn't in there. You have some things about a big distance between the births. Well, more and more modern women are spacing their pregnancies. That's not a risk. So I think midwives need to take control and start to put together some midwifery guidelines. So if we can help, if this can help, please let us know. Next slide, please. What do we need to do? Okay, next slide, please. This is the ICM campaign for this year, the push campaign. We need 1 million more midwives in the world. With 1 million more midwives, we could prevent 67% of maternal deaths, 64% of newborn deaths, and 65% of stillbirths by 2035, saving more than 4.3 million lives by 2035. That's midwives. That's us. How powerful is that? So we need to be pushing for more workforce of autonomous, well-trained professional midwives. Next slide, please. How do we do this? This is how we do it. The 3 pillars of ICM: education, regulation, association. These are the strength that advances the profession. What about education? You need global standards that define minimal entry requirements and curriculum. We have that from ICM. We need to ensure midwives are trained to ICM essential competencies. We need to make sure midwives are practicing their scope and know how to refer. We need to know that we are legitimized and that we have career recognition and that we have pay equity. We need to also make sure that we have a foundation for not just your university, but ongoing education. And this is where AppKind is so important. It's not just about going to the university and never read another thing in your life. This is about ongoing education. What about regulation? This is legislation that formally defines the midwife and the scope of practice. We need those licensing regulations to make sure that ongoing competence is verified. Every year, I have to give money to the Nurses and Midwives Board, and I have to tick many boxes, and I have to guarantee that I've had so many hours of CPD to make sure that my ongoing education is competent. And then every year they audit randomly people, and you have to produce the evidence. We need to be able to protect midwives from being, if they're asked to work outside their scope, we need to make sure there's legal accountability, and we need autonomous regulation to protect from the medicalized hierarchy. Midwives need to be in charge of midwives, not doctors. Doctors need to be in charge of doctors. Nurses need to be in charge of nurses, and we all need to work together as respectful, collaborating professionals. An association. I've spent, 30 years actively involved in the College of Midwives. I've been the secretary of a branch. I've been the vice president. I've been the president. I've been the media spokesperson. The college's voice is so powerful. It unifies midwives to advocate for safe staffing, working conditions. It amplifies the voice of midwives to government. It makes sure that there's professional support and in-servicing. It advocates against workplace harassment and also violence and moral distress. And it represents midwives in all those workforce planning and policy development. It's so powerful. But if we have strong education, strong regulation, and strong association, we have strong midwives. And if we have strong midwives, we have strong and healthy women. And if we have strong and healthy women, we have a healthy, powerful, well society. Next slide, please. This is me. I sometimes feel like the little goldfish in the water, going into a big meeting with very powerful people, and I feel like a little goldfish, and I have to strap on a big shark's fin, and I have to pretend that I'm not really shaking in my boots. So being brave is not about having no fear. It's about being able to overcome it. It's being able to have the big voice even when the voice is shaking. And the more you practice your voice, the more you realize the world doesn't collapse when you are strong. So we all need to be the little goldfish that straps the big fin on our back and swims on down to join the party. Next slide, please. This is my ending. Do we view childbearing women as full of capacity or catastrophe? Everything that we do and say becomes an echo of this central core belief. When you look at a woman, do you see her power, her strength, her potential? Or do you see her blood pressure, her fundal height, her PPH, and everything that could go wrong? How do we see women? And I worked for 20 years in high-risk hospitals in delivery ward, seeing everything. And when I went from that to working in private practice for 10 years and mostly home, I had to unlearn all my fear, and I had to start to see women as capacity, not catastrophe. So thank you, everybody. Be strong, strap on your shark fin, and go change the world. Thank you.
Check. Yes. Ladies and gentlemen, please join me in giving another warm round of applause to Professor Hannah Dahlen for that enlightening presentation. So, Professor Dahlen, thank you for sharing such valuable insights with us. Your presentation has truly deepened our understanding of how evidence-based practices get antenatal care, especially in moments where timely decisions and compassionate support are equally essential. Jadi, teman-teman, dapat disimpulkan bahwa praktik intranatal care berbasis evidence harus kembali pada prinsip bahwa persalinan adalah proses fisiologis, sehingga tidak semua perempuan membutuhkan intervensi medis. Perempuan harus diberikan ruang dan hak penuh untuk menentukan pilihan, termasuk mengatakan tidak pada tindakan yang tidak mereka inginkan dengan dasar informed consent yang jelas. Ketakutan utama ibu, risiko, dan kematian harus dijawab bukan hanya dengan pendekatan safe care, tetapi juga positive birth experience yang menghargai martabat perempuan. Pendekatan pelayanan harus bersifat individual karena tidak semua perempuan memiliki tidak setiap perempuan memiliki kebutuhan yang berbeda. Dalam konteks Indonesia, perhatian besar perlu diberikan pada anemia, pendarahan, dan preeklamsia sebagai penyebab utama komplikasi. Selain itu, aspek psikososial dan dukungan komunitas masih perlu diperkuat, terutama pentingnya screening dan keterlibatan lingkungan sekitar. Upaya deteksi dini seperti pemeriksaan USG sebelum 24 minggu juga menjadi bagian penting dalam meningkatkan kualitas layanan. Kemudian ada kesenjangan antara layanan klinis dan realitas di masyarakat harus dijembatani melalui pemberdayaan perempuan dan komunitas serta memastikan keberlanjutan pelayanan atau continuity of care. Model midwife-led care terbukti efektif dan perlu diperkuat dengan peran dokter difokuskan pada kasus dengan indikasi klinis. Profesi bidan juga perlu didorong untuk memiliki otonomi dan keberanian dalam mengadvokasi kebijakan yang berpihak pada evidence. Akhirnya, pelayanan intranatal harus berorientasi pada woman-centered care, menghormati, tidak merendahkan, bebas dari kekerasan, serta memberikan otonomi penuh kepada perempuan. Dengan kolaborasi yang kuat antara tenaga kesehatan dan komunitas, kita dapat memastikan bahwa setiap perempuan mendapatkan pengalaman persalinan yang aman, bermakna, dan bermartabat. If I might briefly reflect, one important point that stands out is how the integration of recent evidence allows care providers to navigate complex situations with greater confidence while still maintaining a patient-centered approach. Yes. We now move into the part of session where your voices take the lead, everyone. Our Q&A discussion for Professor Hannah Dahlen. Like for those joining us on site, please raise your hand and our committee will assist you with a microphone. Kindly introduce yourself briefly and keep your question concise. For our online participants, you may submit your questions through the chat box or use the raise hand feature. Our team will help relay them to the stage. We also have a small token again of appreciation for those who actively participate, so don't hesitate to join in. All right, ladies and gentlemen, the floor is now open. Anyone want to asking question or just want to have a discussion, please? Okay, our on-site, there are none for on-site. Probably we can check for the Zoom. Anyone from the Zoom has asked any question or wanting a discussion? Yeah. Yeah. All right, so there is a question from, so, okay, let me read it. Hi, Hannah. It is a verb analogy you say that fish catch a ship. Actually, in Indonesia, we thought see all pregnant women as at-risk pregnancy, maybe because our mother came from various socioeconomic background. Is it possible to give a customized ANC or antenatal care, like a personal trainer, or any suggest from you what exactly we can do in antenatal care, for example? Is it clear now?
I think the answer is continuity of midwifery care. That's exactly what a personalized trainer is, a continuity of midwifery care. So if you have a midwife who goes through the journey of pregnancy, birth, and postnatal, they know where you come from. They know what your issues are. They know about your hemoglobin. They know what your diet is. They know what your concerns are. And they are putting in place strategies to help you. To consider every woman at risk means the way we act will be with a risk lens. The way we need to act is with a public health, primary health care lens. Most of the socioeconomic issues and cultural issues are to do with things that aren't necessarily about blood pressure. They aren't necessarily about clinical things. They are about diet. Yeah, they are about mental health. They are about being able to get enough of the right food to be fed. They are about shelter. They are about support. They are about domestic violence. They are about things that come from us putting in community support and preventative healthcare measures. So I would say continuity of midwifery care is your personalized trainer.
Thank you so much. That gives us something concrete to think about. Jadi untuk jawaban feedback dari Professor Hannah itu untuk personal trainer, personal trainer ini difokuskan seperti COC atau continuity of care. Memang untuk seperti hal-hal yang klinikal seperti tensi, kemudian USG dan sebagainya memang tidak bisa dilakukan secara personal. Tetapi ada hal yang bisa dilakukan secara personal seperti khusus ke pemberian edukasi ke psikososialnya, tentang budayanya, tentang mungkin ada support dari keluarga dan sebagainya. Jadi itu yang dimaksud yang bisa diberikan sebagai personal trainernya. Tapi kalau untuk yang sesuatu berkaitan tentang klinikal itu tetap tidak bisa dilakukan secara personal. Semoga menjawab untuk pertanyaan dari yang pertama ini. Kemudian ada pertanyaan kedua. There is a second question, Prof. Hannah. Alright. Yeah, all right. So, hi, Prof. Hannah. I'm Dwi from Poltekkes Bengkulu. She is from Bengkulu, outside of Java. Yeah, it is outside. I have read one of your articles titled "What Woman what women want if they were to have another baby, the Australian Birth Experience Study or PEST cross-sectional national survey. And I would like to ask, what is the best way for women to have a stronger voice in decision making, especially in a country where there is still a strong tradition that decision making must be approved by the husband or male family members? Do you mind providing your contact so I can reach out for further consultation. Thank you.
Yeah, so this is one of the papers that Hazel presented this morning. And again, I'd reiterate what Hazel said this morning. Get everybody to answer the best survey Indonesia, because then we will find this out and we can take the knowledge to government and say these are the issues. Hazel and I are very happy to supply our contacts to you. I think that the laws I put up, they don't say the husband controls a woman. They say a woman controls what she wants to do. So we need to go back to what is the law and remind women of their rights. But I understand culture and tradition make it so hard for some women to do things they want and not what their husband. So you have unique challenges that we don't have in Australia, but the best survey will start to uncover what they are.
Alright, thank you. Jadi jawabannya untuk yang ada di Zoom, kontaknya bisa dilihat dari tadi yang presentasi yang sudah diberikan oleh Dr. Keedle. Jadi nanti mungkin bisa kembali ke live rekaman live sebelumnya untuk melihat kontak dari The Best ini. Jadi nanti bisa langsung kontak ke situ untuk diskusi lebih lanjut. Kemudian jadi di Australia tidak ada masalah di mana suaminya yang memberikan keputusan tentang perempuan yang ada di dalam care-nya bidan kita. Nah, ini dari berdasarkan aturan yang sudah disampaikan oleh Professor Hannah itu tidak ada. Jadi itu adalah sesuatu yang unik di Indonesia dan perlu dipelajari lebih lanjut. Mungkin kalau semisal ingin menanyakan tentang kontaknya bisa kembali lagi ke replayan di bagian kontaknya The Best survey tadi ya untuk langsung kontak ke timnya Dr. Keedle sama Professor Hannah. Nah, everyone, I'm so sorry. We're afraid we have to wrap up the Q&A session for Professor Dahlen due to time constraints. Thank you, everyone, for the great participation. Professor Dahlen, okay, all right. Thank you very much for that meaningful. Presentation. Once again, on behalf of all participants, thank you, Professor Dahlen, for your time and for such an inspiring presentation. We truly appreciate your contribution. Ladies and gentlemen, we have now arrived at the final presentation of today's webinar, closing our series of discussions on the continuum of compassionate, evidence-based care. Before we begin, may I again invite everyone both in this room and joining us online through Zoom as well as YouTube Live to kindly direct your attention to the screen where the CV or final speaker will be presented. I encourage you to take a moment to follow along as it gives us a clear picture of expertise behind the insights we are about to receive. Now, ladies and gentlemen, our final speaker is someone whose dedication and contributions have made a meaningful impact in her field. With a strong background in both academic and professional practice, she continues to play an important role in advancing knowledge and improving the quality of care. It is my pleasure to introduce Dr. Wahyu Anis, a respected academic and practitioner. So Dr. Wahyu Anis is a coordinator of Midwifery Study Program, Faculty of Medicine, as well as the senior lecturer at Bachelor of Midwifery Program. So it is Bachelor, Faculty of Medicine at Universitas Airlangga. Dr. Wahyu Anis has an outstanding academic and professional background. She was an awardee of PPI Scholarship between 2021 and 2024, supported by the Center for Education Financial Services and the Indonesia Endowment Funds for Education. She also received the prestigious Australia Awards Fellowship in both 2014 and 2017 under the Department of Foreign Affairs and Trade. She is also actively involved in professional organizations like as an officer of the Indonesian Midwives Association in the East Java region, a member of the Association of Indonesian Midwifery Education known as IPKIN, and a member of the Collegium Midwifery. She has also led Gilead's collaboration with UNICEF, managing fatal child tuberculosis and maternal assistance programs. Next, please. In terms of academic contributions over the past 5 years, Dr. Wahyul Anis has published a total of 10 scientific journal articles that are most of them closely related to today's topic, which is postnatal care. And then next, please. Dr. Wahyul Anis has authored more than 6 books focusing on the practice and education of midwifery, reflecting her commitment to advancing knowledge in this field. Furthermore, she has actively participated in various international workshops and seminars. In 2014 and 2017, she was involved in capacity building programs in research and education and in Adelaide under the Australia Awards Fellowships. More recently, in 2024, she participated in basic and advanced quality improvement training in collaboration with Johns Hopkins University affiliate. Next, she is also actively engaged in various professional activities as seen in the screen. With an inspiring profile, everyone, her achievements truly reflect a strong commitment to both knowledge and practice, something that is essential in delivering quality and compassionate care. In this final session, Dr. Wahyul Anis will be presenting on the topic, recent best evidence in postnatal care. At this time, I would like to invite all of you to warmly welcome Dr. Wahyul Anis to the stage with a big round of applause. Let's have a huge applause for Dr. Anis. Ibu, please join us on stage and kindly proceed the presentation.
Pointernya enggak bisa ya? Oh, enggak bisa. Baik. Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Hello everyone. I'm presented about the postpartum care, and then I think this is very very important. And I am presented by Bahasa, maybe Prof Hannah and Hazel. And I think you are also very very understood by our Bahasa, ya. Baik, Ibu-ibu sekalian dan mahasiswa, hari ini saya akan berbicara dalam bahasa Indonesia ya. Tadi sudah les bahasa Inggris gitu ya. Jadi saya akan menyampaikan dalam bahasa Indonesia di mana untuk postnatal care ini benar-benar atau penting bagi kita untuk pelajari bersama. Next slide. Ya. Ini adalah topik yang akan kita pelajari bersama. Jadi kita akan belajar terkait dengan konsep dari postpartum terlebih dahulu. Kemudian nanti kita akan belajar terkait dengan evidence yang disampaikan oleh WHO. Kemudian nanti juga kita akan bersama-sama menyampaikan apa sih challenging yang ada di postpartum care di Indonesia. Slide. Slide. Nah, ini adalah definisi untuk postpartum care ya. Jadi ada 2 definisi. The first definition for Ministry Health Nasional Indonesia, and then the second definition from WHO. Jadi kalau kita lihat bersama ada perbedaan ya. Jadi kalau di Indonesia untuk postpartum itu pelayanan baru kita berikan, kita baru bisa menjelaskan bahwa oh itu pelayanan postpartum itu sejak 6 jam setelah persalinan. Ya, tapi ketika kita lihat dari WHO bahwa segera setelah bayi lahir itu maka sudah bisa disebut sebagai pelayanan nifas. Ya, dan kalau kita lihat ya kedua-duanya sama, yaitu kedua-duanya berakhir 42 hari. Ya, dalam tanda kutip 42 hari itu adalah untuk ibu postpartum fisiologis. Jadi untuk beberapa kasus ibu postpartum yang patologis bisa jadi lebih dari 42 hari. Di Indonesia fokus untuk postpartum yaitu terkait dengan integrated dan comprehensive manner. Jadi lebih ke bagaimana memberikan pelayanan yang komprehensif. Dan Kementerian Kesehatan mendefinisikan komprehensif ini yaitu dengan kolaborasi interprofesional. Ya, jadi makanya tadi Prof Hannah menyampaikan di persalinan kita juga harus kolaborasi dengan dokter, dengan perawat begitu ya. Kenapa? Karena memang pendekatannya itu agar kita bisa komprehensif begitu. Padahal sebenarnya yang lebih tahu terkait dengan ibu itu siapa sih? Bidan. Ya, yang paling paham itu kan bidan. Yang paling dekat dengan perempuan itu kan bidan, gitu ya. Dokter, perawat itu masih didominasi oleh laki-laki. Sedangkan bidan semuanya adalah perempuan. Sehingga kalau misalnya kita memberikan asuhan ke sesama perempuan, itu sebenarnya akan lebih optimal. Lah inilah perbedaan sudut pandang kita dengan Kementerian Kesehatan yang menganggap komprehensif di sini harus diasuh oleh semua tenaga kesehatan. Nah, sebenarnya ada poin penting yang disampaikan oleh WHO terkait dengan definisi nifas, yaitu critical time. Dan waktu kritis ini bukan hanya untuk ibu saja, tetapi juga untuk bayi, untuk partnernya, suaminya, ya, untuk orang tua, ya, untuk caregivernya dan untuk familiesnya. Jadi justru yang digarisbawahi WHO itu adalah peran serta orang di sekitar ibu dan termasuk ibu. Dan WHO ini kalau bisa kita lihat, dia sudah menyebutkan critical time atau waktu yang kritis. Karena di Indonesia 60-70% ya kematian ada di masa nifas. Jadi tolong berhenti kita hanya fokus untuk kehamilan dan persalinan, ibu-ibu sekalian. Karena apa? Karena kenyataannya banyak ibu yang meninggal pada masa nifas. Kemarin saya dari Gresik ya, ada 4 kematian ibu lagi ya pada masa nifas. Dan salah satunya itu disebabkan karena preeklamsi. Dan harusnya pada saat kondisi seperti itu, bidan melakukan monitoring pada kasus tersebut, tetapi tidak dilakukan. Kenapa? Ternyata karena bidan desanya cuti. Sehingga ketika dalam kondisi kondisi ibu membutuhkan tata laksana segera, akhirnya tidak bisa dilakukan dan monitoringnya terlambat sehingga sampai terjadilah kematian. Itu yang kita hadapi bersama. Jadi hal-hal yang seperti itu menjadi hal yang penting untuk kita perhatikan lebih lanjut. Next slide. Nah, ini adalah schedule or jadwal ya, jadwal untuk postpartum visit in Indonesia. Dan kalau kita lihat untuk schedule-nya sama dengan WHO. Jadi untuk schedule 4 kali selama masa nifas kontrol ke fasilitas layanan kesehatan itu sama dengan WHO. Tetapi kalau kita lihat dari jadwalnya yang ada di sini ya, ini nanti berbeda dengan WHO. Begitu ya. Kenapa kok berbeda? Ada kemungkinan ini melalui proses diskusi di Kementerian Kesehatan, di mana Kementerian Kesehatan memang memberikan waktu yang berbeda pada kunjungan ketiga dan kunjungan keempat. Bagaimana dengan implementasinya? Next slide. Nah, ini adalah implementasinya. I have studied Hannah in Indonesia in puskesmas in Surabaya. 4 to 7 mother postpartum, and then ibu yang lengkap atau complete visit setelah melahirkan itu only 8.11. Jadi selebihnya cuma sampai KF3. Ya. Jadi kalau misalnya kita lihat dari laporan Kementerian Kesehatan semuanya di atas 90%, tapi kenyataannya cuma 8,11% yang saya temukan. Dan ternyata setelah saya kaji dengan kualitatif, ternyata dari ibu mengatakan bahwa saya sudah tidak membutuhkan kunjungan karena Bu Bidan mengatakan jahitan saya sudah kering. Jadi kenapa kok di sini sampai KF3 saja? KF3 itu kan 10 hari ya, ibu-ibu sekalian ya, 10 hari setelah persalinan. Ternyata setelah dia kontrol, Bu Bidannya ngomong sudah kering jahitanmu, jadi kamu tidak kontrol tidak apa-apa. Itu yang terjadi. Ya, dan ketika saya tanya kualitatif ke tenaga kesehatan, ternyata tenaga kesehatan juga punya perspektif yang sama. Yaitu apa? Ketika jahitannya sudah sembuh, tidak kontrol, tidak apa-apa. Padahal ada ibu nifas itu yang meninggal tepat di 42 hari. Dan ketika dia meninggal di 42 hari, dia masuk masa nifas enggak kematiannya? Masuk. Dan dia masuk dalam kategori maternal death atau mortality death. Ya, jadi kalau misalnya kita lihat di sini, memang menjadi penting sekali kita untuk menjelaskan bagaimana kunjungan nifas ini secara baik. Slide berikutnya. Next slide. Nah, ini. Jadi masih adanya persepsi tenaga kesehatan dan masih kurangnya penjelasan tenaga kesehatan kenapa sih perlu kontrol nifas. Begitu. Karena apa? Jika ibu ini tidak mengetahui pentingnya kontrol nifas, maka ibu ini tidak akan datang. Makanya tadi Hazel Hannah menjelaskan pentingnya komunikasi, pentingnya debrief ya tadi ya. Jadi sebenarnya peran kita itu di mana sih? Banyak ngomong. Ya, jadi kita harus banyak melakukan debrief. Tapi challenging di kita itu adalah waktu tunggu ya, ibu-ibu sekalian ya. Waktu tunggu. Jadi waiting time in puskesmas when midwife give service the mother only 10 menit ya Bu ya. Dibatasi berapa menit? 10 menit? Yang di puskesmas? Only 10 menit. Only 10 menit Hana. Lah, apakah dengan 10 menit itu akan optimal? Pasti tidak. Waktu 10 menit itu tidak cukup, ibu-ibu sekalian. Jadi kalau misalnya kita lihat memang banyak homework ya bagi kita ya, banyak PR bagi kita untuk memperbaiki kualitas pelayanan kita. Next slide. Nah, ini adalah schedule dari WHO. Jadi kalau kita lihat ada perbedaan schedule yang ada di sini. Ya, tapi untuk secara kuantitatifnya sama-sama 4 kali. Ya, next slide. Nah, ini adalah rekomendasi dari organisasi dari Amerika yaitu terkait dengan obstetrik di mana kalau misalnya memang kita temukan ibu dengan komplikasi ya atau ibu yang patologis maka pelayanan nifas itu boleh lebih dari 42 hari. Jadi kalau misalnya kita mengenal adanya trimester 4, ya. Jadi kalau misalnya kehamilan kita mengenal trimester 3, lah trimester 4-nya itu di mana? Itu adalah di masa nifas. Dan ini akan kita lakukan sebenarnya ketika ibunya patologis. Kalau ibunya fisiologis berarti harusnya cukup 42 hari saja. Nah, masalahnya apakah negara kita merekomendasikan ini? Tidak. Ya, karena di negara kita masih 42 hari. Kenapa? Karena kita ada keterbatasan pembiayaan untuk implementasi ini. Ya, jadi ini memang belum diimplementasikan di negara kita juga. Next slide. Ya, jadi untuk trimester 4 hanya direkomendasikan untuk kasus-kasus patologis di mana tugas kita adalah melakukan monitoring dan memastikan bahwa kondisi ibu sudah fisiologis atau sudah kembali lagi seperti sebelum hamil. Next slide. Nah, ini adalah beberapa hal yang direkomendasikan oleh WHO ya ibu-ibu bidan. Jadi kalau kita lihat sudah dijelaskan di sini terkait dengan hal-hal tersebut. Salah satunya adalah penguatan pemulangan pasien. Ya, salah satunya adalah penguatan pemulangan pasien. Next slide. Ini adalah hasil studi saya terkait dengan pemulangan pasien ibu-ibu bidan. Jadi untuk penelitian ini saya melakukan di 7 Hospital in Surabaya. And the result ya, dan hasilnya di sini kita dapatkan screening mental health ya any 8% ya, 8.11%. And then untuk yang pemberian edukasi ya, pemberian edukasi di sini belum optimum ya 59% terkait dengan family rules-nya, peran dari keluarganya belum banyak dijelaskan ya. Dan kalau kita lihat di sini juga ya terkait dengan informed consent, terus kemudian terkait dengan pengkajian kepuasan pasien dan yang lebih penting lagi di sini adalah pencatatan untuk di buku KIA belum optimal. Ya, jadi harusnya semua hal ini itu bisa kita optimalkan 100%. Tapi kenyataannya masih seperti ini, ibu-ibu sekalian. Ya, apakah kita selama ini sudah melakukan screening kesehatan mental? Sudah atau belum? Saya kemarin sudah melakukan inisiasi di Puskesmas Kota Surabaya, tetapi memang hambatannya challenging-nya adalah waktu tunggu. Waiting time the patient. Ya, sehingga untuk screening kesehatan mental tidak bisa dilakukan secara optimal. Ketika kita tidak melakukan screening, apakah kita bisa mengetahui bahwa di situ ada masalah? Tidak. Jadi memang screening kesehatan mental ini merupakan hal yang paling penting sebenarnya. Komprehensif, pemberian pelayanan komprehensif itu salah satunya yaitu terkait dengan kesehatan mental ini. Oke, next slide. Nah, next slide. Ini adalah beberapa evidence yang disampaikan oleh WHO. Mungkin nanti ada beberapa evidence yang sudah ibu-ibu ketahui ya pada saat proses pelayanan. Yang pertama yaitu terkait dengan physiological assessment. Ya, apa saja sih yang paling penting kita kaji pada masa nifas ya. Di sini ada bleeding ya, terus kemudian tonus ya atau kontraksi, TFU ya, kemudian suhu. Kemudian di sini juga ada pemeriksaan rutin lainnya dan ini dilakukan 24 jam pertama. Untuk di Surabaya atau di puskesmas, kita rawat inap di Surabaya, di puskesmas sampai berapa jam? Apakah 24 jam atau sudah 6 jam? Berapa Ibu? Minimal 24 jam. Karena kemarin saya mendengar BPJS memberikan peraturan baru untuk ibu hamil untuk ibu nifas fisiologis cukup 6 jam di Fasiankes. Dengar nggak ya Ibu ya? Pernah dengar kebijakan tersebut? Lah, padahal WHO sendiri itu sudah men-statement di sini bahwa harusnya dalam 24 jam pertama itu kita masih tetap melakukan monitoring ya. Tapi kenapa kok BPJS menentukan 6 jam lah, ini saya juga kurang paham. Jadi evidence di kita memang belum banyak digunakan ya. Kemudian kalau kita lihat di sini juga ada beberapa hal yang harus kita pastikan seperti BAK ya. BAK minimal 6 jam harus dipastikan ya ibu-ibu sekalian, jangan sampai memulangkan pasien dalam kondisi pasiennya belum BAK karena di sini sudah direkomendasikan. Slide. Nah, untuk screening tuberkulosis, apakah di puskesmas dan TPMB sudah dilakukan saat ini? Sudah? Sudah ya Bu? Selalu, always, in pregnant, and then postpartum? Karena ternyata WHO ini merekomendasikan ya, dan di negara kita ini adalah negara endemik ya ibu-ibu sekalian. Jadi harusnya memang TB ini bisa kita optimalkan untuk dilakukan screening. Ya, oke, next slide. Nah, ini adalah intervensi terkait dengan psikologikal tadi ya. Jadi kalau misalnya kita ketemu pasien kemudian ada masalah, maka yang kita optimalkan yaitu tata laksana yang tidak farmakologis. Kalau misalnya farmakologis pun di sini yang direkomendasikan cukup menggunakan paracetamol. Saya rasa ibu-ibu di fasilitas layanan kesehatan sudah melakukan ini ya, ibu-ibu ya. Oke, next slide. Nah, ini juga selain paracetamol dari WHO juga memperbolehkan kita menggunakan analgesik NSAID. Ini jika diperlukan. Jika tidak diperlukan sebenarnya tidak perlu juga. Kenapa? Karena sebenarnya untuk ibu nifas mengalami nyeri di area luka jahitan itu normal atau tidak ya? Normal ya. Jadi nggak mungkin kalau misalnya kita ada luka terus kemudian kita tidak mengalami nyeri atau sakit ya. Jadi di sini selain kita juga direkomendasikan menggunakan analgesik begitu ya, juga di sini direkomendasikan untuk menggunakan yang non farmakologis. Jadi apa nih non farmakologisnya? Yaitu lebih banyak kita memberikan teknik refleksi, menjelaskan atau memberikan edukasi. Jadi harapannya di sini memang kita tidak banyak memberikan intervensi. Next slide. Nah, ini adalah juga terkait dengan upaya preventif ya. Untuk saat ini ya saya lihat sudah banyak perubahan di lapangan. Kalau dulu setiap ibu nifas baik normal atau tidak normal diberikan antibiotik ya. Ya dulu ya. Ketika saya menjadi mahasiswa saya diresponsi oleh preceptor mesti tanya kenapa diberikan antibiotik untuk profilaksis. sekarang sudah tidak diperbolehkan. Jadi kalau misalnya kita mau mencegah terjadinya mastitis, maka upaya yang kita berikan adalah memberikan konseling laktasi, memberikan edukasi terkait dengan laktasi, ya. Dan di WHO ini juga direkomendasikan terkait dengan pencegahan konstipasi. Ibu-ibu, kalau kita edukasi konstipasi itu menjadi edukasi rutin atau ketika ada keluhan aja ya biasanya? Ketika ada keluhan aja ya biasanya. Padahal di sini itu jelas-jelas WHO itu menuangkan statement tersendiri. Jadi kemungkinan besar konstipasi ini banyak terjadi pada ibu nifas. Dan ini merupakan hal yang fisiologis sehingga upaya yang kita lakukan adalah memberikan edukasi agar dia tidak sampai terjadi konstipasi. Next slide. Nah, ini adalah screening untuk kesehatan mental. Ibu-ibu untuk screening kesehatan mental sekarang menggunakan apa? EPDS. EPDS-nya digunakan kapan? Kapan kita mulai menggunakan EPDS untuk ibu nifas? Pada saat hamil, oke, pregnant. Terus pada masa nifasnya kapan? Kalau menurut Kementerian Kesehatan kemarin, EPDS kita gunakan pada KF3. KF3 itu pada postpartum 10 hari. Ya. Tapi apakah betul itu direkomendasikan pada KF3? Karena pada 10 hari postpartum ketika ibu mengalami kecemasan, ibu menangis sendiri, apakah dia pasti depresi? Tidak. Jadi definisi depresi itu sebenarnya dimulai minimal adalah 14 hari postpartum. Ketika sebelum 14 hari postpartum kita screening EPDS, apa yang terjadi? Ada kemungkinan overdiagnosis. Ya, jadi jangan sampai hal tersebut terjadi. Kalau ibu-ibu memang sesuai dengan anjuran Kementerian Kesehatan, 10 hari sudah dilakukan EPDS, tolong konsultasikan dengan psikolog. Karena apa? Saya khawatir ketika sebelum 14 hari ini sudah dilakukan screening EPDS, akan banyak temuan ibu postpartum yang depresi. Padahal kan bisa jadi itu hanya postpartum blues. Postpartum blues itu normal atau tidak normal? Normal. Jadi postpartum blues itu normal ya. Karena saya pernah menjumpai bidan itu postpartum blues itu patologis. No, postpartum blues itu normal. Jadi upaya yang kita lakukan memberikan support dan sebagainya. Kalau kita menjelaskan postpartum blues itu patologis berarti hampir semua ibunya nanti akan kita rujuk. Akan kita refer. Padahal itu adalah overdiagnosis. Gitu ya. Oke, next slide. Nah, ini adalah terkait dengan apa ya? Mobilisasi. Ya, WHO menjelaskan jika ada ibu hamil yang tidak memiliki kontraindikasi, maka tidak diperlukan adanya pembatasan mobilisasi. Ini adalah untuk kasus-kasus yang fisiologis ya. Jadi untuk kasus-kasus yang patologis berbeda dengan rekomendasi ini. Dan rekomendasinya ini hampir sama dengan rekomendasi kita sebagai ibu yang tidak postpartum. Yaitu apa? Bisa melakukan latihan fisik kurang lebih 150 menit per week. Ya, jadi kurang lebihnya per harinya berapa? Per harinya kurang lebih adalah 30 menit. Biasanya dalam 1 minggu itu dianjurkan untuk 2 hari istirahat. Ya, jadi tidak setiap hari juga. Ya, itu yang direkomendasikan untuk latihan fisik. Next slide. Nah, ini adalah kontrasepsi. Saya rasa untuk kontrasepsi ini sudah sesuai ya ibu-ibu sekalian. Semua ibu nifas paling tidak harus kita lakukan konseling kontrasepsi. Pemberian informasi ini menjadi hal yang paling penting untuk kita berikan pada ibu postpartum. Next slide. Nah, breastfeeding ini juga sudah kita lakukan. Ibu-ibu semuanya sudah melakukan IMD di Fasiankesnya. Inisiasi menyusui dini. Sudah ya, karena IMD itu dapat mendukung untuk breastfeeding secara eksklusif yaitu 6 bulan. Next slide. Nah, Ini adalah rekomendasi WHO, tadi sudah saya sampaikan. Jadi paling tidak dari WHO merekomendasikan selama masa nifas 4 kali kunjungan. Dan ibu nifas itu paling tidak dalam 24 jam pertama sudah harus mendapatkan perawatan dari tenaga kesehatan. Next slide. Nah, ini terkait dengan informasi. Ini sudah dijelaskan oleh Hazel sebenarnya. Jadi tugas kita adalah the brief. Menjelaskan. Bidan banyak ngomong. Ya, jadi kalau misalnya kita itu tidak banyak menjelaskan, maka pasien kita tidak pinter. Kalau pasien kita tidak pinter, kira-kira nurut enggak? Nah, itu. Jadi di sini adalah peran kita untuk melakukan debrief. Oke, berikutnya slide. Nah, ini adalah terkait dengan persiapan pemulangan pasien. Ya, dalam persiapan pemulangan pasien ya dibutuhkan terkait dengan pemberian edukasi yang optimal. Jadi jangan sampai pasiennya itu pulang tetapi tidak siap, ibunya enggak siap, keluarganya juga tidak siap untuk memberikan support kepada dia. Jadi tugas kita ketika sebelum kita memulangkan pasien, harapannya adalah pasien kita berikan edukasi secara optimal. Next slide. Nah, home visit. Ibu-ibu kapan kita melakukan home visit? Hasil penelitian saya kemarin, ibu-ibu bidan baru melakukan home visit ketika ibu nifasnya ada komplikasi. Padahal WHO di sini apakah rekomendasinya untuk ibu yang komplikasi? Tidak. Jadi sebenarnya tujuan WHO itu adalah memang kita diminta untuk home visit. Ketika kita tidak home visit, kita tidak tahu bagaimana lingkungan rumahnya si ibu, bagaimana support sistemnya si ibu, bagaimana lingkungan ibu yang nyaman itu seperti apa. Jadi memang home visit ini menjadi tanggung jawab ibu bidan. Ya, tapi kerjaannya Bu Bidan banyak ya. Kemarin kami ke Banyuwangi, bahkan ada bidan di puskesmas itu karena keterbatasan orang, kalau merujuk pasien dia sebagai drivers ambulan. Luar biasa sekali ya. Kalau di Surabaya enggak ada ya? Enggak ada. Bu Eva ya, Bu Eva juga driver ambulan ya. Oke, next slide. Nah, ini adalah terkait dengan bagaimana sharing, pentingnya kita sharing ya. Sharing terkait dengan apa? Terkait dengan upaya promosi kita kepada pasien. Jadi memang banyak ngomong itu yang diperlukan. Next slide. Nah, ini ada rekomendasi dari WHO terkait dengan SDM, ya human resource ya ibu-ibu sekalian. Jadi kalau misalnya ibu-ibu bidan merasa beban saya besar, beban saya terlalu berat, ini juga bisa diadop gitu ya. Karena apa? Karena sebenarnya WHO juga memperhatikan bagaimana beban kerja kita sebagai bidan. Next slide. Nah, ini terkait dengan home based record. Pada saat kita home visit, yang kita perlukan adalah bagaimana kita melihat situasi dan kondisi rumah sebagai support sistem ibu. Jadi kalau misalnya kita nggak home visit, kita tuh tidak tahu apakah di situ ibunya menggunakan air yang bersih, apakah suaminya siap siaga untuk memberikan perawatan ibunya, kita tidak tahu. Makanya memang home visit ini dianjurkan untuk dilakukan pada ibu nifas maksimal 7 hari setelah persalinan. Next slide. Nah, ini tidak direkomendasikan ya ibu-ibu sekalian. Antibiotik untuk upaya profilaksis sudah tidak direkomendasikan. Rutin memberikan laksatif juga tidak diberikan. Dan rutin memberikan antibiotik profilaksis untuk yang tidak ada komplikasi tidak direkomendasikan. Dan vitamin A pada ibu nifas juga tidak direkomendasikan. Siapa di sini yang masih memberikan vitamin A pada ibu nifas? Ada ya. Karena ada laporan, karena ada guidelines dari Kementerian Kesehatan yang mewajibkan kita memberikan vitamin A. Buku WHO ini terbit tahun 2022, Ibu-ibu sekalian. Kementerian Kesehatan bukunya terbit tahun 2019. Sehingga antara evidence dengan apa yang diwajibkan di Indonesia ini memang belum sesuai. Jadi WHO itu sudah menjelaskan ketika ada 2 kelompok ibu, saya berikan vitamin A, 1 kelompok tidak diberikan vitamin A, kesehatannya sama. Jadi kalau kita masih tetap memberikan vitamin A sebenarnya tidak efisien. ya. Jadi ini adalah rekomendasi WHO. Oke, next slide. Nah, ini adalah challenging ya di Indonesia. Next slide. Lah, home visit belum optimal. Sepakat ya, ibu-ibu di sini ya. Home visit belum optimal. Kemudian di sini juga untuk penggunaan buku KIA juga belum optimal. Buku KIA itu untuk apa sih? Kira-kira? Satu, sebagai media edukasi. Dua, dokumentasi. Tiga, komunikasi antar tenaga kesehatan. Jadi kalau buku KIA tidak lengkap, apakah kita bisa memberikan continuity of care? Tidak. Karena semua data kita itu ada di buku KIA ini. Ya. Jadi khusus untuk ibu-ibu ketika apalagi yang di rumah sakit, kalau puskesmas biasanya mengisi ya, rumah sakit mohon buku KIA diisi. Dan masih saya temukan untuk buku KIA ini jarang sekali diisi untuk kunjungan nifas. Kalau pada kunjungan hamil, setiap kali habis kunjung selalu ditulis tanggal ya. Selalu ya. Bagaimana dengan nifas? Tidak selalu. Yang saya temukan ketika pada kunjungan nifas tidak pernah ditulis tanggal kontrolnya. Sehingga di sini menjadi peluang ibu-ibunya akhirnya tidak kontrol. Ya, sosial ekonomi yang rendah, ya, kemudian rujukan yang terlambat, ya, ini masih menjadi kendala di kita. Next slide. Kemudian terkait dengan culture ya, ini ada beberapa budaya yang di sini mungkin juga tidak benefit bagi ibunya. Kemudian interprofessional collaboration. Jadi ibu-ibu kalau ANC ya, antenatal care, diminta ini ya, berkolaborasi dengan yang lainnya. Waktu ANC terpadu, siapa aja Bu yang dilibatkan? Dokter, laboran, gizi, psikolog. Setelah dari tenaga kesehatan yang lain ini, siapa yang akan menentukan ibunya ini tata laksananya seperti apa? Bidan. Bidan tetap harus menjadi leadernya. Jadi kita boleh bekerja sama tim, tapi bidan harus menjadi leadernya. Ibu bidan kalau sudah mendapatkan hasil dari beberapa tenaga kesehatan dibaca yang komprehensif, itu menjadi salah satu plan untuk asuhan kita berikutnya. Dan harusnya asuhan kita di nifas saat ini sudah kita rencanakan sejak kehamilan kemarin. Itulah continuity of care. Jadi jangan sampai nanti, oh ketemu saya, advice saya seperti ini. Besoknya ketemu Bu Agnes, advice Bu Agnes berbeda lagi. Harusnya Bu Agnes itu mengikuti perencanaan yang sudah saya lakukan. Karena apa? Karena pemeriksaan asesmen terlengkap itu kan pada kunjungan awal. Gitu ya. Jadi kalau misalnya kunjungan berikutnya biasanya kita cenderung lebih cepat dan hasil pemeriksaannya pun biasanya di situ juga tidak sekomplit kunjungan awal. Jadi harapannya kita bisa memberikan continuity of care. Lah, mental health screening ini juga belum optimal di kita. Next slide. Nah, ini adalah penelitian saya ya kemarin di tahun 2024 dan di sini kita dapatkan bahwa memang IPC ini memiliki kekuatan korelasi yang lebih tinggi. Artinya apa? Kita boleh berkolaborasi, begitu ya. Tapi temuan kemarin pada saat saya penelitian itu juga ada yang menarik gitu ya. Ketika seorang ibu nifas dilakukan screening oleh psikolog dengan Bu Bidan, ternyata yang hasilnya itu menggambarkan realita adalah yang di Bu Bidan. Kenapa? Karena ketika dilakukan screening oleh psikolog, kira-kira ibu ini baru ketemu psikolog itu satu kali ya ibu-ibu ya. Ketemu langsung di screening, kira-kira nyaman nggak? Nggak nyaman. Jadi biasanya hasilnya itu kurang sesuai. Tapi kalau Bu Bidan yang mengkaji, itu sebenarnya ibunya akan lebih open untuk menyampaikan sesuatu. Jadi kalau misalnya ibu-ibu, Bu Wahyul screeningnya oleh psikolog aja, sebenarnya kurang tepat. Screening harus oleh bidan. Kalau ada temuan silakan kolaborasi dengan psikolog. Harusnya seperti itu. Jadi di Indonesia wanita itu lebih percaya kepada Bu Bidan. Ya, bukan kepada tenaga kesehatan lain. Jadi jangan terburu-buru kita merefer ke tenaga kesehatan yang lain. Next slide. Ya, next slide berikutnya. Next slide. Nah, ini adalah rekomendasinya. Jadi rekomendasi kita di sini adalah kolaborasi lintas sektor, kemudian kolaborasi bersama ya. Jika ada problem ya, any problem you can collaborate with others providers ya. Tapi jika memang di situ adalah resiko rendah, maka Bu Bidan memiliki kewenangan yang otonom. Kemudian implementation evidence base, karena evidence base itu sudah terbukti. Kemudian optimalisasi buku KIA. Improvement dari quality services ya, tadi yang sudah saya jelaskan, waktu tunggu 10 menit itu memang sangat tidak mudah bagi kita. Kemudian comprehensive of care. Next slide. Baik, demikian untuk paparan dari saya. Terima kasih. Wassalamualaikum warahmatullahi wabarakatuh.
Ladies and gentlemen, let us give a well-deserved round of applause to Dr. Wahyu Anis for that insightful and enriching presentation. Dr. Anis, thank you for completing today's series of discussion with such valuable perspectives. Your presentation has beautifully highlighted how postnatal care, supported by the latest evidence, plays a crucial role not only in recovery, but also in ensuring long-term well-being for both mother and child. If I may briefly reflect, today's three sessions have taken us through a meaningful journey from antenatal to intranatal and now postnatal care, reminding us that compassionate, evidence-based practice is not a single moment, but a continuous commitment across every stage. We've now reached the discussion segment. For our on-site participants, simply raise your hand and the committee will bring a microphone to you. For those joining online, feel free to drop your questions in the chat box or use the raise hand feature. Anyone on site wanting to ask a question or have a discussion, please raise your hand. All right, I see there are none. Probably we can check from the Zoom if there is any question from the chat box or probably someone raising a hand. All right, so we have Professor Hannah wanting to ask.
Thank you so much. That was so well stepped through. I can see you're an excellent teacher, the way that you did that. And I could hear the word bidan, bidan, bidan going on through the whole talk. So amazing. My question is, with the low postnatal follow-up that you showed in your study and a high rate of deaths from preeclampsia in do you know what proportion of deaths from preeclampsia are occurring postnatally? That would be a really good argument to increase that postnatal support to pick up the blood pressure problems that are being missed potentially.
Yeah, thank you, Prof. Hannah. Preeclampsia is the number one cause to mortality in Indonesia, maternal mortality in Indonesia. And then our observation, the causes for the preeclampsia, number one, we not optimum to screening preeclampsia. Many women pregnant to lose to screening. In maternal and child book, we have the screening to preeclampsia, but not all the pregnant to screening. And then if the not screening, so the mother not give prevent therapy. Yeah, in Indonesia have the prevent therapy to preeclampsia. This is aspirin and calcium, but the providers absolutely not screening and then not give the prevent therapy. And the problem number two in preeclampsia, apa ya? Beberapa itu apa, Van? Several provider afraid to give magnesium sulfate before referral to hospital. Yeah, this is many problem. So the patient preeclampsia or eclampsia in the hospital is not stabilized condition. Yeah, this is condition in Indonesia. Yeah. Ya, kalau di Surabaya ya, in Surabaya in the year 2024, 13% mortality, maternal mortality caused to preeclampsia. Yes, 30%. Postpartum 60%. 60%, yeah. Yeah, 60% from the maternal mortality in the postpartum time, yeah. In Surabaya ya, in Surabaya. No, untuk ya all 60%, and then especially for preeclampsia 30%, 30%. Yeah. Tiga 30%, ya 30%. Iya. In Surabaya ya, Hana. Iya.
All right, thank you. Is that clear now? Thank you so much. I appreciate how clearly that was explained, Dr. Wahil Anis. Anyone wanting to ask a question from here or have a discussion on site? Please raise your hand. I'm trying to see one. Where is that? There will be a souvenir, everyone. There will be a souvenir. Will be transferred right after you're asking questions. So I want to see if there is anyone asking a question or just want to share something, having a discussion here. All right, perhaps we can see the Zoom, the chat box. No one yet. Should I close? Let's go. We still have a lot. All right, over there, finally. Yeah. Ini, parah, parah. Parah. Belakang sana. Nanti ada buah di belakang.
Baik, terima kasih untuk kesempatannya. Sebelumnya perkenalkan, saya Riris Putrisia, mahasiswi profesi bidan semester 3. Terima kasih Bu Wahyu untuk presentasinya yang sangat insightful terkait dengan postpartum care. Izinkan saya untuk bertanya, tadi seperti yang sudah disampaikan oleh Bu Wahyu terkait dengan seharusnya kita itu melakukan yang namanya kunjungan rumah. Namun kenyataannya ini SDM lalu beban tenaga bidan yang sudah dibebani banyak sekali pekerjaan, itu akhirnya membatasi bidan sendiri untuk melakukan kunjungan rumah. Bahkan mungkin teman-teman mahasiswa di sini profesi semester 3 yang melakukan continuity of care juga malah mengalami keterbatasan untuk melakukan kunjungan rumah karena bebannya juga sudah banyak. Apalagi bidan yang sebenarnya sudah banyak sekali beban pekerjaannya di lapangan untuk melakukan kunjungan rumah. Nah, sebenarnya kan kita udah tahu sekali manfaat adanya kunjungan rumah, tapi melihat di lapangan itu sulit sekali untuk melakukan kunjungan rumah. Tidak hanya dari aspek bidannya, tetapi juga aspek pasien dan keluarganya. Mungkin ada pasien dan keluarga yang bersedia untuk dilakukan kunjungan rumah, tapi ada pasien yang dihubungi melalui sosial media saja itu sudah susah. Jadi tidak hanya dari bidannya, tetapi juga aspek sosial budayanya itu susah. Nah, mungkin dari Bu Wahyu, apakah ada tanggapan atau mungkin saran kepada kami seorang calon bidan di masa depan, supaya mungkin aplikatif dari evidence base ini bisa kami lakukan di masa depan. Gitu Bu Wahyu. Terima kasih.
Ya, terima kasih. Iya, jadi memang tantangan itu ada ya. Yang pertama adalah beban kerja. Ibu-ibu bidan, apakah pernah menghitung beban kerjanya selama ini seperti apa? Pernah enggak? Biasanya yang kita lakukan adalah kita cuma ngomong ke kepala puskesmas, saya sibuk, saya banyak kerjaan. Tapi kita tidak pernah menghitung berapa sih beban kerja kita selama ini dan kebutuhan tenaga di kita itu seperti apa. Itu jarang kita lakukan. Sehingga kita memang harus melakukan advokasi kepada kepala puskesmas ya, minimal di sini ya. Karena sebenarnya rekrutmen SDM itu tidak dari puskesmas ya, tapi dari dinas kesehatan. Tapi paling tidak kita harus bergening bahwa memang beban kerja kita itu cukup tinggi. Itu yang pertama. Yang kedua terkait dengan budaya. Luar biasa budaya ini. Jadi mungkin ini yang curhat mahasiswa profesi karena COC ya. Iya. Jangan bandingkan kita sebagai mahasiswa dengan ibu bidan yang ada di puskesmas, apalagi bidan desa. Berbeda. Bidan desa itu sangat dikenal di masyarakat, gitu ya. Kalau mahasiswa ketika mau WA saja ya, WA kadang kan nggak dibales ya. Kunjungan rumah belum tentu mau karena kita dianggap masih orang asing. Tapi bidan desa itu pasti dikenal oleh masyarakat. Jadi challengingnya berbeda dengan kita sebagai mahasiswa. Lah, tapi bidan ini banyak nih beban kerjanya. Apa yang kita lakukan? Yang kita lakukan tentu saja adalah kolaborasi dengan kader kesehatan. Ya, jadi health cadre ya atau volunteer ya maybe ya. Jadi kader kesehatan itu harus kita berdayakan. Karena apa? Karena kalau misalnya kita nggak menggunakan kader, maka kita juga akan kesusahan dalam melakukan pemantauan wilayah setempat. Ya, jadi kader itu merupakan salah satu perpanjangan tangan ya dari bidan. Jadi bisa dimanfaatkan oleh Bu Bidan ketika bidan ada keterbatasan. Mungkin itu ya. Apakah clear?
Is that clear? Okay, thank you. Probably we can take one more right. Please.
Terima kasih Bu Wahyul, ini sangat luar biasa ya presentasinya. Nah, saya sebetulnya ingin dapat informasi karena Bu Wahyul juga aktif di IBPD ya. Nah, apakah sudah ada upaya-upaya dari IBI untuk memperkuat bidan-bidan di lapangan dengan konsep ini? Ini kan hasil eviden yang dilakukan ya. Dan seberapa jauh para bidan sudah menerapkan ini sebagai, mungkin ada yang berbeda tadi dengan pusat ya, panduan-panduan dari pusat, tapi di sini ada rekomendasi yang bagus. Nah, apakah sudah dicobakan di wilayah Jawa Timur gitu? Terima kasih.
Terima kasih Bu Yum. Jadi untuk Ikatan Bidan Indonesia saat ini memang fokusnya adalah di bidan delima Bu Yum. Dan saya rasa memang saya kurang tahu pasti untuk bidan delima karena saya tidak masuk dalam pengurusan bidan delima. Tapi kondisi real seperti ini saya ketahui ketika saya mengikuti program bersama GHPGU ya dalam kegiatan quality improvement bersama MCGL. Jadi kita saat ini mendampingi 9 kabupaten di Provinsi Jawa Timur. Dan banyak temuan yang luar biasa Bu Yum terkait dengan hal tersebut. Salah satunya partograf yang tidak digunakan real time gitu ya. Jadi partograf itu ternyata penggunaannya setelah persalinan selesai untuk mengklaimkan ke BPJS baru dibuat. Itu juga saya baru temukan. Kemudian screening preeklamsi itu ternyata juga tidak dilakukan begitu ya. Kemudian beberapa tenaga kesehatan bahkan dokter saja ada yang takut memberikan, afraid to give magnesium sulfat before referral. Not only midwife, dokter also afraid to give magnesium sulfat before referral to hospital. Jadi temuan-temuan itu ternyata sebenarnya memang kualitas pelayanan di Indonesia ini memang belum optimal. Lah kemarin kami sebenarnya Bu Yum dari Provinsi Jawa Timur bersama Dinas Kesehatan sudah minta ya kepada IBI Provinsi Jawa Timur untuk mengembangkan ini di bidan delima, tapi memang belum bersambut begitu. Itu adalah kendala kita di situ sih. Iya. Ini baterainya habis, lowbat.
Ya, Bu Wahyul, ini sebetulnya tadi saya tanyakan itu karena eh, IBI, pengurus IBI daerah juga bisa melakukan inovasi-inovasi yang mungkin tadi hasil itu tadi bisa menjadi panduan khusus dibuat oleh PD dan nanti itu untuk uji coba lah di wilayahnya begitu. Nah, itu harapan saya mungkin ada inovasi atau perubahan-perubahan update dari tadi panduan-panduan yang dikeluarkan Kemenkes yang sebetulnya ada beberapa yang sudah tertinggal begitu. Terima
Iya,
kasih ya.
ini kemarin kami dapat best practice baik Bu Yum dari Banyuwangi, Bu Susi ya. Bu Susi, apakah masih ada di Zoom? Ibu Susi? Jadi TPMB Bu Susi ini ternyata dia sudah aktif melakukan screening untuk preeklamsi buyung. Bahkan dia sudah menggunakan Excel dan sudah ada rumus-rumusnya. Ya, best practice-nya bagus sih. Lah sebenarnya hal-hal yang seperti ini yang harusnya kita sharing bersama begitu. Jadi ketika kita bisa mencegah ibu itu agar tidak jadi patologis, maka ibu itu tetap menjadi kewenangan bidan. Tapi kalau kita tidak bisa mencegah, akhirnya ibu itu akan terjadi patologis dan itu akan menjadi kewenangan dokter. Lah pentingnya untuk continuity of care itu sebenarnya di sana. Harapan besar kita ibu-ibu normal begitu ya, bukan patologis. Itu sih Bu Yum. Terima kasih. Nanti Bu Yum bisa bantu menyampaikan juga di IVI pusat begitu. Oke, terima kasih Bu Yum.
All right. Thank you so much for that question and for the feedback that Dr. Wahil Anis has given. Probably because we still have a little bit of time, we'll take one more question. Anyone from on site, please? Yeah, please. Ini nggak bisa diminta ganti baterai gitu ya? Gimana?
Assalamualaikum warahmatullahi wabarakatuh. Sebelumnya terima kasih banyak Bu Hayul atas presentasinya luar biasa. Perkenalkan saya Afilda, saya dulu mahasiswanya Ibu juga. Sekarang saya bidan di salah satu TPMB di Surabaya. Jadi gini Bu, saya ingin bertanya terkait continuity of care. Kalau untuk kita aplikasikan di TPMB ya, atau ya di Surabaya ini, saya merasa bagaimana mungkin strategi atau saran dari Ibu ya untuk kita mengaplikasikan continuity of care ini? Karena misalnya nih ada pasien datang apa namanya kunjungan ANC pertama ke kita, misalnya kita kan secara tim ya di TPMB tidak hanya satu orang bidan saja. Misalnya bertemu dengan saya misalnya, oke sudah di edukasi, sudah anamnesa dan segala macamnya. Kita tahu kebutuhannya pasien ini apa, kemauannya pasien ini apa. Kemudian selanjutnya misalnya bertemu dengan bidan lainnya, kemudian dia mendapatkan mungkin pertanyaan yang berulang lagi, edukasi yang berulang lagi, atau bahkan mungkin edukasinya itu tidak sama dengan yang sebenarnya sudah kita sampaikan. Nah, itu mungkin ada saran dari Ibu bagaimana caranya kita sebagai tim di TPMB atau di semua bidan ini ya, cara kita menyamakan persepsi dulu mungkin ya untuk edukasi yang kita berikan. Mungkin seperti itu.
Ya, terima kasih. Langsung saja ya. Saya pernah ada pengalaman membimbing mahasiswa di rumah sakit untuk manajemen gitu ya. Kemudian pada saat praktek manajemen, mahasiswa ini mempraktekkan discharge planning begitu. Pada saat discharge planning ketika bidan ketua tim ini menanyakan ya atau mereview edukasi yang sudah pernah didapatkan, jawabannya cuma satu, ASI eksklusif. Jadi ketika Ibu Nifas itu 3 hari di rumah sakit, karena dia kan pos SC ya, 3 hari di rumah sakit, dia mengakunya hanya mendapatkan edukasi ASI eksklusif. Padahal harusnya dia mendapatkan banyak edukasi seperti nutrisi, tanda bahaya, misalnya ya, istirahatnya seperti apa, kebutuhan cairan, tadi untuk mencegah konstipasi, bagaimana cara dan sebagainya, ternyata tidak didapatkan. Kenapa? Karena biasanya pendokumentasian kita di rumah sakit ataupun di SOWAP itu lebih banyak yang kita tuliskan adalah medical atau medicine. Oh, sudah diberikan paracetamol, sudah diberikan antibiotik, tapi kita jarang menuliskan edukasi yang sudah saya berikan itu apa. Sehingga teman kita tadi di shift berikutnya harusnya membaca, oh dia teman saya tadi yang jaga pagi sudah memberikan ini, jadi saat ini saya harus memberikan ini. Itu yang pertama. Dan sebenarnya continuity of care itu bisa kita inisiasi dengan ketika kita bertemu dengan pasien itu pertama kali, misalnya postpartum kan tadi ya, setelah pasien bersalin, kita kan tahu utuh kondisi pasien seperti apa. Maka kitalah yang sebenarnya merencanakan sebenarnya pasien ini mulai dari sekarang sampai dia nanti mau pulang itu asuhan yang dibutuhkan itu apa saja. Sekali lagi ini asuhan kebidanan, bukan yang dokternya ya, medicalnya gitu. Kalau medicalnya kan kita memang biasanya nunggu advice dokter gitu ya. Kalau ini di TPMB kan berarti kan kita bisa menjadi leadernya begitu. Jadi bidan yang pertama kali ketemu ya, ketemu dengan pasien ini, apalagi di situ adalah postpartum, baru 6 jam postpartum misalnya, maka dia yang seharusnya menuliskan perencanaan asuhan dia sampai mau pulang itu seperti apa. Sehingga nanti ketika temannya yang lain mau memberikan asuhan atau care gitu ya, maka di situ dia bisa melihat yang sudah direncanakan temannya. Contoh simpelnya seperti ini ya, ketika ibu datang pregnant ya, kunjungan pertama, maka biasanya kan kita sudah melihat oh ibunya obesitas misalnya ya, ibunya punya resiko terhadap diabetes gestasional. Maka kita sebagai orang yang pertama kali membuat asuhan dia, kita juga harus berpikir nanti usia kehamilan 24 minggu kita butuh pemeriksaan kadar gula. Lah itu harusnya sudah direncanakan misalnya mulai dari sekarang. Mulai dari sekarang kita juga sudah memikirkan memberikan edukasi terkait dengan diet nutrisi. Sehingga apa? Tidak kebablasan. Apa ya bahasa Inggrisnya kebablasan itu? Ya. Jadi yang saya temui ibu bidan itu fokus, ibu kalau hamil itu nutrisinya yang bagus. Ibu harus berat badannya naik, makannya yang banyak. Tapi ketika berat badannya berlebihan, ya overweight begitu ya, maka akan meningkatkan resiko terhadap terjadinya preeklamsi. Nah itu biasanya yang kita tidak sadari. Seperti itu. Begitu. Jadi perencanaan awal itu penting sih kalau dari saya.
Baik, terima kasih banyak
Ya,
Bu Ayu.
belajar menjadi leader ya sebenarnya ya.
Iya sih Bu.
Ya, terima kasih.
Thank you so much for the questions, and thank you so much as well from the feedback of Dr. Wahyul Anis. All right. Once again, thank you very much for the session that we've had. Once again, on behalf of all of us, thank you, Dr. Anis, for your time and for sharing your knowledge with us today. We sincerely appreciate it. Now, ladies and gentlemen, as much as we would love to continue this engaging discussion, we have now reached the end of our allocated time for the main session. Unfortunately, we do have to bring this part to a close. I would like to take a moment to sincerely thank again our distinguished speakers, Dr. Hazel Keedle, Professor Hannah Dahlen, and Dr. Wahyul Anis for not only their insightful presentations, but also for their openness in sharing perspectives throughout this discussion. It has truly been a valuable exchange of knowledge and ideas. To all participants, both here with us on site and those joining virtually, thank you for your thoughtful questions and active involvement. It is your participation that brings depth and meaning to spaces like this. We certainly hope that everything we have explored today, from the presentations to the discussion, will be useful, relevant, and something you can carry forward into your own practice. And to our speakers, speakers, we wish you continued success and good health. And we hope to have the opportunity to welcome you again in future sessions to share more of your valuable insights. All right, ladies and gentlemen, with that, we have come to the end of all sessions of today. On behalf of the committee, I would like to express our sincere gratitude to all speakers for their insightful contributions and to all participants both on-site and online for your active participation and enthusiasm. It has been a meaningful season, and we hope today's discussion brings lasting impact to anyone in practice. Lastly, thank you for your attention, your energy, and your presence. I'm Emma, your moderator, signing off and wishing you all great day ahead. Good morning, and thank you so much.